We are live, ma'am. Please start.
Namaste and good evening, everyone. A very warm welcome to Onco Forum 2025 Day 4th. We are honored to have you join us for this two-day event. We look forward to insightful discussion and meaningful learning this evening. With immense pleasure, I would like to invite Program Convener Dr. Asim Samar. He is a Senior Consultant Medical Oncology at Bhagwan Mahavir Cancer Hospital Research Center, Jaipur. It's over to you, sir.
Thank you, Team Horizon and Onco Forum for making this possible. And today is the last day of our webinar, and today we will discuss only oncological cancer and mainly endometrial and ovarian cancer. So earlier 4 days we have discussed about the breast, lung, and prostate cancer, and kidney cancer also. So this will be a thorough discussion about the endometrial cancer, what's new in the era of the immunotherapy, molecular testing, and all that. And for that, we are having the Glaxo of stars and the what you call is speakers and the panelist. Dr. Snepreet Kaur is our dear colleague, and she was joining. She was there in JNU Hospital. I guess Sneh, you have left from there.
Yes, sir.
So now you are planning to move to Patiala, I
Yes,
guess.
sir. Yes, sir.
Okay, so she is wonderful lady, and she will speak about role of molecular classification in staging and management of the C endometrium. So, Dr. Sneh, over to you, and we are very excited to listen you about this particular topic. And this is a topic which has emerged in last, you can say, the couple of years, in 1 or 2 years. And now, without molecular classification, we are not planning to do any treatment about the endometrial cancer patient. So, over to you. It's a very important topic. Thank you for joining us. Yeah.
Thank you, sir. Good evening, everyone. So, let me share my screen first. Is my screen visible to all of you?
Yes,
Yes,
ma'am,
yes.
it's visible.
Yes,
Okay.
ma'am.
So, my topic for discussion today is molecular classification of endometrial cancer and its impact on staging and management. So, the learning objectives will be the TCGA-based molecular classification, the 4 key molecular subtypes and their biomarkers, and how it affects the prognosis and the recurrence risk, its incorporation in decision-making for the adjuvant treatment, and its relevance in the Indian and global practice. Initially, the endometrial cancer were classified into type 1 and type 2. Type 1 is usually the less aggressive estrogen dependent, and there is a stepwise progression from the endometrial typical hyperplasia to atypical hyperplasia, then low grade and intermediate grade. And the various mutations, somatic mutations were there in this, and most common P10 mutation and TP53 mutation is seen in the type 2 endometrial tumors, which are usually arise from the atrophic endometrium. And it is usually the high grade tumor and more aggressive. And traditionally, the risk stratification of endometrial cancer is based on the histology, grading of the tumor, stage of the tumor, and lymphovascular space invasion. These all are subjective, and there are inter-observer variability was seen in this stratification. Another limitation of this stratification is that it does not capture the biological heterogeneity. So it was divided into low, intermediate, high intermediate risk, and high risk. In low risk, FIGO stage 1A, low grade endometrioid carcinoma with no LVSI. Intermediate risk usually comprise of stage 1B with low grade and no LVSI and endometrioid carcinoma. High intermediate is grade 3 FIGO 1A with LVSI, and grade 1 or 2 FIGO, FIGO stage 1 regardless of depth of invasion with LVSI. And high risk usually contain the high grade stage 1B and other stages like non-endometrioid endometrial carcinomas, and any stage more than stage 2. So why we need the fine tuning in this risk stratification? Because it will lead to the improved reproducibility and risk prediction. It identifies the biologically distinct subgroups and allows the escalation and de-escalation of the adjuvant therapy, and also aligns with the precision medicine principles. So this is a mutation spectra across the endometrial carcinoma. In 2013, there is the beginning of the new genomic era in which the TCGA data has given us the 4 molecular classification, that is pole ultramutated, MSI hypermutated, copy number low, and copy number high. And there are other recurrent mutation which are also present in the endometrial carcinoma, which include the P10 mutation, TP53, PIK3CA, ARID1A, beta-catenin, and KRAS. So then the TCGA classification was correlated with the histopathology, and the pole ultramutated, MSI hypermutated, and copy number low, they all comprise the endometrioid carcinoma. And the copy number high, in which TP53 mutation is the most common mutation, they usually comprise the high-grade tumors like serous-like carcinomas. So there is a global transformation of the endometrial cancer care from the pre-2013 era to the 2023. In the pre-2013 era, the treatment is based mainly on the histomorphology. In 2013, TCGA data has given us the molecular classification, and then further confirmation and validation and integration of these molecular classification into the clinical guidelines, and now in the FIGO staging 2023. So these are the 4 subtypes of the endometrial cancer, that is P53 abnormality, deficient MMR, pole mutation, and non-specific molecular profile, which is the most common, seen in 50 to 55% of the cases and having the intermediate prognosis. These are usually low-grade tumors. Pole mutation having the best prognosis, seen in 7 to 9% of the patients, and the test is done by the NGS or Sanger sequencing. Deficient MMR having the intermediate prognosis, seen in 15 to 25% of the endometrial cancers, and it is done by the IHC staining using the various MMR proteins, or it can be done by MSI analysis by using the PCR and MSI 5 panel markers. And larger NGS MSI and PCR MSI panels are also used for this type of subtyping. P53 abnormality, which is having the worst prognosis, seen in 15 to 20% of cases, and it is also done by the IHC staining, or TP53 alteration is done by the sequencing. So when we correlate the TCGA and the PROMIS classification, which is the newer classification, so the pole ultramutated correspond to the pole mutated, MSI hypermutated with the MMR deficient, copy number low with the NSMP, they all lead to the low-grade tumors, and copy number high, which is a P53 abnormal, leading to the serous carcinomas. So what is the PROMIS group classification? It is the proactive molecular risk classifier for the endometrial cancer. It used the TCGA data to extract the surrogate markers for the genome-wide analysis, and used to classify these into the 4 categories, which we have already discussed. So first, pole sequence, this is the NCCN flowchart in which pole sequencing is done first. If it is present, then it is a pole mutated. If there is no pathogenic mutation in the pole, then MMR by IHC or MSI testing by PCR is done. If it is normal, then P53 is further checked by the IHC. Otherwise, it is considered as deficient MMR or MSI high. If P53 is normal or wild type, it is considered as NSMP or so pole mutation endometrial carcinoma, they are present in 8% of the cases. It has the excellent outcomes regardless of high risk features or the adjuvant treatment. What are the various high risk features? This is the LVSI present, deeper myoinvasion, or higher grade. So in this type of tumors, de-escalation of therapy is possible, and this is seen in the POTEC-3 trial, in which the relapse-free survival in the pole mutated, it is the curve, this is a straight line. So the adjuvant treatment will not impact on the prognosis, and also the overall survival, it does not impact with the adjuvant treatment in the pole mutated endometrial carcinomas. Then is the MMR deficient, which is seen in 30% of the cases. It gives us the importance of radiation. And in these 2 Kaplan-Meier curves, these 2 curves are the first is the RT curve, and second is the chemo along with RT. So this will tell us that there is no apparent benefit for chemotherapy even in stage 3 disease. And it also gives us the opportunity to use the immune checkpoint blockade. And also screening for Lynch syndrome is to be done if MMR is deficient. Then the NSMP, which is the most common type, majority are indolent, and it is the treatment is based mainly on the clinical features. P53 abnormality, which is the most lethal subtype, present in 15% of cases and accounts for the 50 to 70% of the endometrial carcinoma mortality. So this NSMP having the intermediate prognosis, further risk stratification using the beta-catenin L1-CAM ERPR may help in further stratification of these tumors. So this is a future strategies. So in this type of tumors, adjuvant therapy decision is guided by the stage, grade, and LVSI. So when we talk about the double classifier, in which two mutations were seen, so like in pole mutation and P53 abnormal tumors, it behaves more like the pole mutated, not the P53 abnormal. Similarly, in MMR deficient and P53 double classifier, it will act more as a MMR deficient, not as the P53 abnormal. So genomically, all the double classifiers with pole mutated and P53 abnormality segregate with the pole mutated, not with the P53 abnormality. And this is similar with the MMRD and P53 abnormal. So when there are multiple classifiers, so pole mutated trumps the other two, that is MMRD and P53 abnormality in terms of genomic profile and prognosis. So they are classified as pole mutated. And if pole is not wild type and MMRD is present and P53 mutation is there, then it is classified as MMR deficient tumors. So how we test these tumors? Already discussed that ISC is to be done for MMR, P53, and pole sequencing should be done if available, and assign the molecular class in the hierarchical order, that is pole mutation if it is present. If not, then MMR deficient. If not, then P53 abnormality, and then NSMP. In MMR protein analysis by ISA, two markers are used, MSC6 and PMS2. If these are deficient, then further testing need to be done, and then genetic counseling is to be done to exclude the Lynch syndrome. If it is present, then MMR proficient or they are MSS. So the how to apply this in clinical practice? These tests should be done on the dilatation and curettage specimen with the first biopsy sample. 3 IHC markers in which P53, MSC6, and PMS2, and somatic mutation analysis of the pole with exon 9, 11, 13, and 14. So one-stop shop testing on biopsy and curettage should be done. And most accepted strategies, IHC for MMR protein to antibody approach, ERP53 should be done on the biopsy and curettage. Pole mutation analysis also to be done in all cases, but if not available or cost is the factor, then it should be done in at least in high-grade tumors and low-stage carcinomas. And then the further adjuvant therapy to be decided accordingly. And in TP53 mutated tumors, HER2 testing should be done for all the patients. So how this molecular classification is integrated into the FIGO staging? Mainly in stage 1 and stage 2 tumors, it will lead to the upstaging and downstaging, mainly with the P53 abnormality and the pole mutation. The other should be notified in the staging system. For example, if there is a stage 1 and 2 tumor surgically staged and it came out to be pole mutated, so this will lead to the downstaging of the stage to stage 1A. Similarly, if the stage 1 to surgical staging staged endometrial cancer is found to be P53 abnormal, then it is staged as 2C with M for the molecular P53 abnormal. So it is upstaged. Rest other molecular markers, that is MMR deficient and NSMP, should be recorded for the future use for the data collection and therapeutic implications. And this is and there is an integration of the molecular markers in the risk stratification, like stage 1 to pole mutated tumors are included in the low risk group, and in the high risk group, stage 1 to 4A P53 abnormal tumors are included in the high risk. These are the three major advancements. First one is pole mutated stage 1, 2 in the low risk, and stage 1 to 4A in the P53 abnormal in the high risk group, and substantial LVSI comes into the high intermediate group. So this is the comparison of all the three pole ultramutated, MSI hypermutated, that's MMRD, and SMP group that is copy number low and copy number high P53 abnormal. So in this, the therapeutic implication is we can de-escalate the therapy, and in MMRD, immune checkpoint inhibitors are need to be studied, and in NSMP, they are usually ERPR high, and so hormonal therapy is incorporated, and P53 are usually HER2 positive, so trastuzumab-based therapy can be given in these patients. So similarly, on the extent of surgery, pole mutated, they may not need the aggressive surgery, and P53 mutated patients may need the more aggressive surgery. And on prognosis, usually P53 is the worst having the worst prognosis, pole mutated having the best prognosis, and MMRD and NSMP having the intermediate prognosis. So its impact on MDT decision making. Various studies have shown that 30 to 35% of the treatment plan changes after the molecular profiling. It prevents the overtreatment in the low risk pole mutated tumors and prevents the undertreatment in P53 abnormal high risk cases. So in pole mutated, consider de-escalation, may omit RT or chemo. In MMRD, standard risk-based therapy based on the clinical factors, and consider immunotherapy if advanced endometrial tumors. In P53 abnormal patients, escalate therapy. Chemo plus RT is often recommended, and in non-specific molecular profiling, it is mainly based on the clinico-pathological risk factors. These are the emerging markers. There are beta-catenin L1 CAM, which may further refine the NSMP prognosis, and various molecular guided trials are ongoing. So the personalized adjuvant treatment become the standard of care. The main challenges in implementation are the cost and availability of pole sequencing, turnaround time, pathologist expertise, and limited resources in low and middle income settings. So what are the various solutions? Universal MMR IHC should be done, and in high risk, high grade tumors, prioritize doing P53 IHC and pole mutation testing. So this is the ongoing trial POTEC 4A, which mainly study the molecular profile-based adjuvant treatment in high intermediate risk group, which observed that in 2025, the observation was that 46% of the patient with favorable molecular profile has avoided the RT, and the unfavorable have used pelvic RT instead of vaginal brachytherapy in high intermediate risk group with unfavorable molecular profile. And there is another trial, ongoing trial, that is the Rainbow trial, that is redefining adjuvant treatment in endometrial cancer based on the molecular profile, in which all histological subtypes, resected endometrial cancers are included, and molecular classification is done. P53 abnormal, all stages are included with P53. This is the red trial. In this, they have studied they are studying maintenance PARP inhibitors. In MMRD, that is the green trial, in which they are incorporating the anti-PD-1 inhibitor. And in NSMP, which is the using as maintenance hormonal therapy, and for pole mutated in all stages, no adjuvant treatment is given in this trial. This is the similar. So take home as test MMR, P53 and pole mutation, combine results with stage, grade, and LVSI, and assign the ISGO Estro ESP risk grouping and tailor the adjuvant therapy accordingly. So molecular classification is now standard of care. Integrate into the MDT decision making, use results to personalize the adjuvant treatment, and stay updated with the evolving guidelines. These are my references. Thank you.
Thank you, Sneh. It was a wonderful talk. Actually, we usually set in the OPD and say like how to do the test and all that. But you clearly said like at least P53 pole mutation and MMRD you should be doing there. And once we are clear in our thought, then we will implement, and initially first few percentage of patient will do the test, and after that we will be applicable. We will apply to everyone.
Yes, sir.
Surely the thing is they need to be supported by some commercial organization or TP and all that. Pole mutation we need to start in our center also, but it is wonderful to tailor the treatment according to their molecular classification. Actually, sometimes we are doing little over, and sometimes it's under treated. So fine tuning can be done with the molecular testing only. So it will be surely in 1 or 2 years, I guess. Everybody is doing and tailoring the treatment according to the protocols. So thank you very much. It was a wonderful talk. Thank you, Dr. Snehapreet. Now I would invite our next colleague, Dr. Preeti Agrawal. She is the consultant medical oncologist in Narayana Hospital, and she will be speaking on paradigm shift in the management of the endometrial cancer. And it is a continuation of the Dr. Snehapreet's talk, I guess. And Dr. Preeti Agrawal, is over to you.
Thank you, sir, for the invitation. So, good evening, everybody. My
Good
top, my topic is how we have shifted the paradigm in management of advanced endometrial cancer. So, without wasting time, let's start. So, as we all know, my screen is visible, no?
Dr.
No,
Preeti.
no, ma'am. Yeah, no, yeah, please. Yeah, Sakshi.
Okay.
Hmm.
Is it visible now?
Yes, it is visible. Paradigm shift in management of advanced endometrial cancer.
Okay, sir. Okay.
Please go ahead.
Yes. So, endometrial cancer is the sixth most common cancer occurring in women, and it is 15th overall. This is a Globocane 2022 data. The endometrial cancer were reported in 4.3% patients, almost 1 lakh deaths were associated with endometrial cancer. This is the Indian data. So almost 18,000 cases were new cases that has been reported.
ये आपको किसने बोला कि 8:30 बजे अभी करना है? तो फिर आपने कैंसर के में डाला ना अभी लिंक क्यों डाला है?
I think the organizers has to mute other people.
Please continue, ma'am.
Yes. So the uterus cancer in India, it was reported in 17,000 new cases were reported in 2022, almost 7,000 deaths, and 5-year prevalence is almost 53,000. So there has been heterogeneity in classification of endometrial cancer. Early stages are stage 1 and 2. Stage 3 is locally advanced and stage 4 is metastatic disease. And we will focus on stage 1. Both germline, stage 4 today, both germline and somatic mutation increase the risk of developing endometrial cancer. As we all know, Lynch syndrome is associated with MMR mutation and it is associated with almost 3% cases of endometrial cancer. BRC mutations has been associated with endometrial cancer as well, and P10 mutation, it is basically seen in mostly in sporadic mutations of endometrium, and it can be genetic as well. So as Dr. Snehapreet discussed in detail, there are 4 major molecular subtype of endometrial cancer. The best prognostic one, which is polymutated, and the tumors have brisk lymphocytic infiltration and very high response to IO, very good prognosis. MSI high, again high lymphocytic infiltration response, high response to IOs, and it is seen in almost 30% patients. Copy number low and copy number high. Copy number low is p53 wild type or non-specific molecular type, which is most common type of endometrial cancer. Another is copy number high, p53 abnormal, which is the poorer, which has the poorest prognosis, and it is seen in almost 15% patients, and it has very high chances of relapse. So depending upon the molecular subtyping, the FIGO stages has been changed. Has been some changes. The polymutation and there is no the polymutations with any degree of LVSI or histological type. The polymutation comes in, which is the mutation, the disease which is confined to uterus with cervical extension comes in stage 1A, while p53 abnormal mutation and which is either with very small myometrial invasion or without any cervical invasion comes in stage 2. So there is upgradation of stage with p53 abnormality and downgradation of stage with poly abnormality. And there is risk stratification depending upon the mutation and the local stage of the disease, low, intermediate, high, and high risk. So, going to unmet need of in advanced endometrial cancer, stage 1, 2, 3 are treated by local treatment, including surgery, radiation therapy, chemotherapy, depending upon the stage of the disease. And advanced stages, if they are debulkable, then surgery followed by systemic therapy. If not, then systemic therapy alone. The 5-year survival of stage 4B endometrial cancer has been very, very low. It is only 17%, and the risk of recurrence increases as the stage of disease increases. So stage 4 patients are highest risk of recurrence, and experience relapse with first-line therapy as and the first-line standard of therapy in MMR deficient endometrial cancer is chemo plus IO as multiple phase 3 data. After multiple phase 3 data, until IO approval in first line, in most recommended IO in second line, and there is unmet need in these women. So establishing first line treatment of endometrial cancer, the first line chemo as paclicarbo. This is a GOG 209 study where metastatic endometrial cancer patients or advanced endometrial cancer patients were randomized to either paclicarbo or TAP regimen, which included doxorubicin, cisplatin, and paclitaxel, the primary endpoint being overall survival, secondary endpoint being progression-free survival. So, updated overall survival suggests the paclicarbo is not inferior to TAP regimen in in relation to overall survival. However, it has significant lower toxicity. So paclicarbo has become standard of care in first line therapy of advanced endometrial cancer. So coming to hormone therapy in advanced endometrial cancer, for the patients of women with recurrent disease, in patients with low-grade endometrioid adenocarcinomas which has high ERPR positivity, hormone therapy with progesterones have been the standard of therapy, but there has been problems with that also. In endometrial cancer, there is lack of standardization in tissue processing for ERPR positivity, and there is lack of clear cutoff limits. Also, there is confusion regarding optimal timing and selection of tissue for determining the receptor status. So the overall response rate with progesterones is almost 23%, with median progression-free survival of 3 months and overall survival of almost 10 months. Other hormone therapies which can be used are tamoxifen, fulvestrant, and AIs. So coming further, defining personalized treatment for advanced endometrial cancer based on molecular profiles. The lessons which we have learned from adjuvant high-risk endometrial cancer. This is a POTEC3 data which we are completely aware of, in which patients with endometrial cancers were randomized to either chemoradiotherapy versus chemotherapy alone, and the primary endpoint being overall survival and failure-free survival. And we can see in stage 3, there is improvement in overall survival and failure-free survival with the addition of chemotherapy to the radiotherapy, which has now become standard of care. So as we dig deeper, we found that we see the maximum benefit of chemotherapy in stage 3 endometrial cancer is with p53 abnormal, where we can clearly see the separation of grafts, while in POL mutated and MMR deficient, it is not very clear, and there has been benefit in non-specific type of endometrial cancer. So the most benefited one are the poor risk ones. So now combination of IO in the second line therapy of advanced endometrial cancer. This is Keynote 158 data. So Pembro showed a robust, durable anti-tumor activity in previously treated advanced MSI high tumors, and with very high overall response rates and of almost 48%, median progression-free survival of 13 months, and overall survival not reached. This is a MMR deficient tumor in second line setting. Keynote 146 is where hermatinib and pembrolizumab in patients with previously treated advanced endometrial cancer, regardless of MMR status, it also showed benefit. And the median progression-free survival was 7.4 months. In non-MSI high, it was 7.4 months. In MSI high, it was 26 months. And total overall survival was 17.2 months, while in MSI high it was not reached. So Keynote 775 also demonstrated superior efficacy of second-line pembro plus lenvatinib versus chemotherapy in advanced endometrial cancers. Now establishing chemotherapy plus IO as a first-line standard of care in advanced or metastatic or recurrent endometrial cancer. This is DOE study with durvalumab plus paclicarbo, followed by durva maintenance with or without olaparib, was used in first-line treatment for newly diagnosed advanced endometrial cancer. Olaparib can also, this is based on the theory that olaparib also enhances the activity of durvalumab through its ability to promote anti-tumor immune response. So the result of DOE are consistent with the proposed mechanism of action of PARP inhibition in combination with checkpoint blockages. So the dual blockages. So the patients with newly diagnosed advanced endometrial cancer, randomized depending on the MMR status, disease, whether recurrent or advanced, Asians or rest of the world, into 3 classes: paclicarbo durvalumab, PCD, paclicarbo durvalumab plus olaparib, followed by either durvalumab maintenance or olaparib maintenance. The primary endpoint being progression-free survival, the key secondary endpoint being OS and safety. Almost 30% patients were Asians, rest are non-Asians. Advanced stages, FIGO stage 4 patients were almost 40%. Recurrent patients was almost 50%. And newly diagnosed stage 3 were 5 to 7%. MMR proficiency was 80% and deficiency was 20%, as seen in as we see in general. PDL1 status was also measured. 70% patients had PDL1 positive and 30% had negative. HRR mutated were present in almost 13 to 15% patients, and non-HRR HRR was not mutated in almost or unknown in rest of the patients. So almost 70% patients could start maintenance post chemotherapy. So almost 70% patients, 70 to 80% patients could start maintenance therapy. This is PFS data in ITT population. And the 12-month PFS rate increased from in paclicarbo arm from 41% to 48% in paclicarbo durva arm to 61% in paclicarbo durva plus olaparib arm. So the hazard ratio being 0.71 and 0.55 with significant improvement in progression-free survival. And there is also improvement in overall survival with the hazard ratio of 0.59. Now, going to subgroup analysis, in MMR deficient populations, we can clearly see the graphs are separating very nicely with 12-month PFS from improved from 43% to almost 70%, and with a hazard ratio of just 0.41. Also in MMR proficient patients, there is improvement in PFS with a hazard ratio of 0.57. So overall response rate and improved from 59% to 62% in patients which received all the 3 drugs, chemo, durva and olaparib. And duration of response also improved from 7 months to 10 months to 18.6 months in paclicarbo plus durva, paclicarbo durva plus olaparib arm. Similarly, overall survival, it significantly improved in MMR deficient population, and also it is improved in MMR proficient population, although the graph separation is not that great, but statistically the hazard ratio was 0.69. So in PDL1 positive subsets, and there is improvement in overall survival and progression-free survival. When we see by subpopulation analysis in MMR proficient population, and so good PDL1 score and polymutation, TP53 abnormality, all actually benefit with addition of paclicarbo and durva. Similarly, paclitaxel durva plus olaparib, it is improved. All subtypes actually benefited from addition of durva plus olaparib. There is no major increase in any adverse event, which is similar with other immunotherapy and olaparib. So, NCCN guideline recommendation. First line therapy, paclitaxel or paclitaxel durvalumab in MMR deficient population, it is now recommended. These are ESGO Astro guidelines, which also recommend addition of IO to chemotherapy in first line therapy. If it was not used in first line, then it is recommended to be added in second line. These are the IO trials, first line IO trials, which has compared, which have used Atizo, dostarlimab, pembrolizumab, and durvalumab. So all have shown good results in MMR deficient population, and pembrolizumab is approved in MMR proficient population as well, except for carcinosarcoma, because it does the study in pembrolizumab did not include carcinoma sarcoma patients. So summarizing, while early stage endometrial cancer is highly curable, recurrent metastatic continues to pose challenges. Treatment of women with advanced endometrial cancer should be guided by patient's condition, extent of disease, prior therapies, and molecular profile. And multiple data have established IO as the standard of care in first-line MMR deficient endometrial cancer, but there's still unmet need in MMR proficient one. So data from DOE has shown a significant benefit of 15 months after adding PARP inhibitor in MMR proficient patients. With this, I thank you. And I'm
Thank you, Dr. Preeti. Yeah, Dr. Preeti, thank you very much for your wonderful talk. And actually, this endometrial cancer is now, previously we used to thought like it is a very easy to treat, but nowadays it's going to be a challenge for the clinician to treat and decide about the adjuvant therapies. Earlier we used to say like stage 1A, 1B, or 2 at least, or we see the grading and all that, and then we say like there is the no requirement of the adjuvant chemotherapy, and
go
you
for
go for
radiotherapy.
vaginal brachy or something, right? But now the scene will change. You agree, Dr. Preeti?
Yes. Now we are involved in the tumor boards of endometrial cancer very, very frequently.
So molecular classification is, yes, it is a need of the hour, and now whether we now we will start pushing the patient to go for the doing molecular testing at least, right? Okay,
Yes.
thank you, Dr. Preeti, and you have throw the light on the very emerging topic. Thank you very much. Now I will be moving for a panel discussion. For that, I would invite Dr. Lalit Sharma. He is our dear colleague and working in Manipal Hospital, Jaipur, and his role will be moderate a session on evolving treatment paradigm with immunotherapy in endometrial cancer. So, Dr. Lalit, over to you. I could say to Lalit.
Thank you for your kind introduction and for the invitation also. I also want to thank you and confess that thank you for making a moderator in this particular session because the kind of data there is and how the field is evolving, it is very difficult to sit on the other side of the table as a panelist and answering these questions. So I believe there is a galaxy of star panelists which are here who are going to throw some light both on the current practice and on the day-to-day, the current available data also. I hope my slides are visible.
Yes, they are. But make it slideshow mode. Yeah.
Yes, it is.
Okay, so we have a galaxy of learned experts to discuss this particular topic. I would like to invite Dr. Arnu Patni ma'am, Dr. Lalit Mohan Sharma sir, Dr. Purva Tak ma'am, Dr. Pulkit Nag, Dr. Ankit Agrawal for this particular discussion. I hope all of them are.
Sir,
Yeah.
Dr. Ankit Agarwal is stuck somewhere. He'll join us in between. We can carry on till
Yeah.
then.
And rest of them all are there.
Yeah.
Yes.
So, endometrial carcinoma is one disorder which is gradually rising both in incidence and prevalence. As more and more westernization of the culture is there, more and more prevalence of the metabolic syndromes are there, more patients are being diagnosed. As the healthcare facilities are improving in the tier 2 and tier 3 cities, we are able to see more of these patients. So I would like to understand the current scenario from our very senior learned colleagues, especially Dr. Anu Patni ma'am. Ma'am, what is the current scenario regarding the incidence and prevalence of endometrial carcinoma, and what changes have you seen in the recent past, ma'am?
As far as the incidence is concerned, we all know that it is the sixth most common cancer. And in the recent times, about I think almost 17 to 18,000 new cases have been seen per year. As far as my practice personally is concerned, in practice we have seen a substantial change in the scenario of endometrial carcinoma in past 1 decade, you can say. Like Dr. Asim said, it was earlier considered to be the easiest and the best gynecological malignancy to manage. Now, the newer classification has, of course, confused many of us, in actual clinical practice. Apart from that, we are seeing more and more cases in younger age, maybe because of better diagnosis, maybe because of some genetic evolution or mutational changes, more and more. So fertility preservation is now becoming a big concern in these cases. Another thing is that with without, we are in a transition phase actually. So earlier we were not using molecular classification, incorporating that in our management strategies. So we many times the malignant endometrial carcinoma, which was thought to be low risk, presented sometime afterwards in an advanced or distant metastatic way. So that phase is now there. So now we are gradually moving towards a better prognostic evaluation and a better adjuvant treatment tailoring of the patients. But this is a transition phase. Very soon, I think we will have a much better scenario, especially with the coming out of results of POTEC 4A and the Rainbow trials. So that is my practical input.
Very wonderfully put,
Lalit,
ma'am.
Dr. Lalit, can I add something to whatever Madam has very, very meticulously she has described many factors, but probably the other risk factors that why there is rising incidence could be related to the like the age of menarche is going down every 6 months, every decade, like every 10 years you see the age of menarche is going down, and the like overall estrogen exposure is higher in the women many times as a result of hormonal imbalance, many times as a result of PCOS, which also is common these days, and sometimes hormone replacement therapy also. So in addition to the lifestyle changes and other factors related to obesity, diabetes, and metabolic risk factors like you mentioned, I think this hormonal exposure also is increasing, and probably that remains one possible contributory factor for a rise in the endometrial carcinoma, and more we see in the younger age group also.
Definitely,
Yes,
sir.
definitely hormonal exposure, hormonal scenario is changing. So more and more risk factors are incorporated in the form of lifestyle, obesity, hormonal scenario, so on and so forth. Yes.
And one thing, madam, I would add, Dr. Lalit,
Sure.
actually, in the estrogen exposure is very high in our country or underdeveloped countries because of the dairy products, and this will be not recognized by the Western countries because they have a very tightly regulated system where they cannot increase the estrogen level in the milk. But in our setting, everyone here and there, they are giving oxytocin injection to the animals, domestic animals, and for the milking. So it is nowadays it is very high level of estrogen in the cheese, butter, and milk products, and it is consumed by the society everywhere, and that's the reason why they are having this PCOS and PCOD, and later on they will be in the younger age group, or maybe in later age group they will be having this kind of the hyperplasia, or you can say the atypical hyperplasia, and converting into the cancer. And this
So
will be recognized by the only our country, or this kind of the underprivileged country.
can I ask one question to my colleagues here? We have
Yes, madam.
Dr. Asim, Dr. Lalit, and all others. Do you see any rise in incidence of male breast carcinoma of late?
Yes, 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 yes.
We are definitely facing a estrogenization kind of a thing in our population in general as such. So maybe estrogen related problems are going to
Yes,
increase.
it is there, madam. It is there. Earlier, only 1% of the breast cancer
Yes,
used to be a male breast cancer. Now it has increased. That is for sure.
so definitely there's a scenario change.
But
Yes.
I'm thankful, Dr. Samir, for bringing us this important issue of milk, in fact.
Yeah, very
Many
true.
of us are very fond of taking milk, and mothers are also fond of giving milk to all the children. So that looks very, very relevant to us. Yeah,
The
over to you, Lalit
the
sir.
what you call is prevalence studies have shown nowadays the milk is coming, which is not the milk which was used to produce in 1970. So the major content of the milk has been changed.
Yes.
So the what you call is the demographic doctors and all that, now they are saying, but the data are very hidden, because then they need to sell their milk, and everything is finance based.
So I
Yeah,
think
so
this
let's
is
go
the
ahead.
first and foremost take-home message and a great insight that probably this organic farming which we are talking is not just a fancy talk, and probably we need to change our practices, how our dairy products, how our agricultural products are being introduced, and there needs to be more tighter regulation onto that. So one is that the incidence is rising because of these various regions these learned panelists have told us. Second is the importance of the stage also. The more and more the disease becomes advanced, the poorer and poorer becomes the kind of prognosis. So may I ask Dr. Apurva Tak, ma'am, what do you feel? Is there any change in the current scenario of the presentation of these disorders you have seen, or what's the ballpark figure how these disorders are kind of presenting to you? What percentage is localized, regional, or distant?
Yeah, absolutely. Thank you, sir, for the question. And also, I thank Asim, sir, for bringing in such an interesting webinar, which is much needed to actually incorporate these molecular markers in our daily routine. So yes, since why talk about my overall experience, but just as I've landed here in Rajasthan, suddenly many patients with, sir, early endometrial cancers I'm, getting. So it's in this span of 9 months, there are 5 patients with me who are actually, I'm looking forward for fertility sparing endometrial cancer management. So these were all patients who were actually undergoing IVFs. And then this is what happened, that they came across that they never had any problem, but because of this infertility checkup that they were undergoing, that is when they could actually detect either endometrial hyperplasia with foci of atopia or frank malignancy for that matter. So endometrial cancer definitely, one is that it is rising in the early young people, as Asim sir rightly pointed out, and even Ranu ma'am. And the other thing which I see, because endometrial cancer always presents with some sort of symptom. It is not like a silent killer like ovarian cancer is. So it will always present with some format of irregular bleeding, or when postmenopausal bleeding for that matter. So it tends to get detected earlier. So yes, we are doing a lot of minimal invasive procedures. We are able to do laparoscopic staging
You have
surgery.
to put a percentage, a ballpark figure for the three various presentations.
Pardon, sir?
localized versus loco regional versus distant at the time
Yeah.
of presentation. I agree that there must be a slight bias. You being a surgeon, the localized disease might be coming more to you. Just trying to get the lay of the land. What are the various proportions you are getting?
To say, if I talk about advanced, which is like stage 3 and 4, then it's just 15% of the endometrial cancers which will actually present in the later stages. Most of them you get in the early stages when surgical staging is possible.
Okay, so now probably here we see a slight, maybe say filtering or presentation bias. Dr. Pulkit, what's your current experience initially presenting patients? What particular proportion of your patients are loco-regional or distant metastatic?
Sir, around 70 to 80% mostly are localized only. And since in the last 2.5, 3 years of practice, only I have seen in my hospital, I'm talking about as a practicing OPD physician, hardly 3 to 4% de novo metastatic uterine cancer I have seen. Although the data is alarming of around 18 to 20% have already shown, but in my clinical practice, most of them are still localized or loco-regionals.
Wonderful. And Dr. Lalit Mohan sir,
I think I agree. Most commonly, it is the early stage disease, and rarely we see metastatic. Of course, the percentage is close to 80% plus is localized disease.
If I may add here, can I just add a word here?
Please, ma'am.
Yeah, we are actually seeing more and more, like Apurva also mentioned, people come from infertility clinics, more and more endometrial hyperplasias. In fact, after definitive surgery, almost 30 to 40% turn out to be low grade endometrioid carcinomas, but more and more in the non-invasive phase or hyperplasia we are seeing. That is also one thing.
So that is probably one sigh of relief that as we are moving ahead and as the treatment modalities are reaching far and beyond, and we are able to identify more and more early stages of endometrial carcinomas.
Yeah, that's right.
And but unfortunately, still, especially in third world settings such as ours, we still find patients in locally advanced or metastatic or recurrent settings. And so far, the backbone for the treatment or care for these patients have been cytotoxic therapies, especially taxanes, doublets such as taxanes along with platinum compounds. We have tested various combinations, single agent, double agent, and unfortunately, most of have done poorly. Though among these, taxanes along with platinum compound doublets have shown the best results, but there is a huge vacuum in this particular setting. The issue becomes more complicated or perplexed in the second line setting, wherein the response rates dip pretty much, be it whatever cytotoxic therapy you use. So there is a huge vacuum wherein you want to see whether there are some other agents available which could improve these particular outcomes in this particular setting. And here comes the role of immunotherapeutic agents. And the major reason for that is because a significant number of endometrial carcinoma patients have high new antigen loads, and a number of the tumor infiltrating cells have also been seen to be pretty high as compared to other disorders. So this laid the foundation for introduction of biomarkers and immuno-oncology drugs here. So if I may ask my learned panelists, what are the biomarkers which we usually test in this pool of patients, especially the advanced setting? And if I may start from Dr. Anu ma'am, could you please let me know what all biomarkers you are using?
So we are talking about in de novo advanced patients?
Yeah, ma'am. Yeah.
Yeah. So I think at first presentation, we do have to go ahead with all the biomarkers. In my practice, primarily, although ideally we should do poly first, but due to some logistic reasons, we go ahead with MMR and P53 first by IHC. And if none of them is if they are positive, then we go ahead with poly, because pol would be the driver mutation in that case. And in advanced cases, we would definitely like to go for ERPR, and sometimes in second line settings, maybe with HER2 also. Any
Dr. Apurva, your take on that?
Yes, sir. So if we talk about the advanced cancers, definitely we'll go with what the ESMO update 2025 says. So we are supposed to do the IHC markers for P53, MSH2, MSH6, MLH1, and PMS2. And apart from that, we do NGS for pole, and apart from that, CTNNB1 and L1 CAM also are poor prognostic markers. And apart from that, we also do ERPR and HER2 new. So these are the markers, especially for serous cancers. If we are talking about serous, we should look into the factor of, doing these as well.
I think CTN1B and L1 CAM can be done in if we have NSMP profile.
Yeah, so ma'am, these are like what all markers. So these are the entire markers that we have for various settings that we can do when applicable.
So, Dr. Lalit Mohan sir, any other particular biomarker you would like to add? And second question is, do you like to go ahead all of them upfront itself, or there is any particular sequencing you do, or how do you go about it, sir?
So first thing, like all the biomarkers have been enlisted very well by Dr. Apurva and Dr. Ranu. And about the sequencing part, yes, in the no resource limitation, then we would like to do all the testing by NGS platform. In case resource limited settings like all we take in the end, and we do IHC based testing, including P53, ERPR, HAR2. All these are taken first along with the MSI also.
And so, what proportion of your patients are able to undergo all these biomarkers? A ballpark figure, sir?
Less than 20% or so.
Very true.
So, Dr. Pulkit, if a very sound clinician and a very good counselor such as Lalit Mohan sir is only able to convince 20% of the patients, what's the scenario in your OPD?
So before Pulkit says, let me say something. Like, it is not the person who convinces the patient and family. It is the center where one is working. So like Pulkit is working in different setup. We are dealing highest number of the government scheme patients. So everyone comes with that hope. Asim is also smiling because he sails through in between both the groups. So Pulkit can tell because he was trained in resource limited setting, but he now serving in a better setting, and even in impaneled, like there is no limit to many things. Pulkit, over to you with this small note.
So, sir, in endometrial cancer, one thing is what we should do, and one thing is what we are doing. So, to be very honest, if it's a very sound patient is there, no barriers are there, so definitely I will go with all whatever my learned panelists have talked about, all the biomarkers, if there is not a limit. But what I am doing practically, sir, I am first of all is doing MSI or IHC based MMR or only MSI testing. If a little affordable, I would like to do a HER2 testing in the second point. Apart from them, I am not doing the full NGS panel or a molecular panel for any of my endometrial patient, because the hospital which I am also working is also not a very upgraded upmarket hospital. So in the limited resource setting, I am doing these two tests prominently, sir.
So you are not doing P53 in the beginning?
Unfortunately, no, ma'am. I am leaving P53. I am doing only MSI, MMR, and if possible, HER2. I am not doing to P53, ma'am.
Okay.
So, Dr. Asim sir, I believe in your scenario, does this ratio changes to 80% versus 20%?
Not really. Not really. But I'm sure with the discussions and insights, we might push with the confidence and then it will change.
Sir, if I can just make a point here, a quick point. So P53, I would suggest that, because the reason being that it will straight away change your
High
whether
risk.
high risk or high intermediate, and then your the management changes. So this is one thing that if at all we can do, we can try for the MMR and P53.
No, I don't do it because I'm very sure that even if it is turned to high risk, the patient will not afford the high risk treatment. So I
Right,
stopped at the first level only.
right, sir, right.
Actually, practically speaking, if we are talking about advanced and recurrent cases, maybe they are all high risk only. So,
Scenario, basically, very well put, ma'am, that they are already advanced or recurrent, and they are already high risk, and they are already going to either receive immuno-oncology drugs or not. So
Yes.
if you
Yes.
withhold the kind of immuno-oncology markers, that is depending on the logistic scenario, that makes sense. But if someone says that he or she is not able to afford MSI testing, I believe it's going to be very difficult for them to afford the immuno-oncology drugs
very
also.
true.
So I believe if the ultimately molecule is not going to get delivered, I think testing all this is going to be in vain, and we are going to unnecessarily probably put the patient in a dicey situation, wherein if it turns out to be positive and then they are not able to take it, they'll go home with a low morale.
So, Dr. Lalit, can I add to this, whatever you
Yeah.
are saying? One thing about the testing being done. So, I think most of these tests, if we are doing TP53, MSI, HAR2, will not cost too much. So, I think this is like not very expensive investigations. The advantage is, even if the patient cannot go for IO based therapy, sometimes some of us may be having a clinical trial. So anybody, like many times the PI, the principal investigator, they are in search of having a adequate patient, and the trials are not being done because we don't have the MSI or the TP53 or other things. So my suggestion will be that we at least do complete workup. May not be full NGS of like more than 2 lakh rupees, but at least minimal we do it, so that tomorrow also we can plan for any treatment. And once the patient is getting the report, tomorrow the IU may be available at a lower price what we are assuming today. So I think we should do test rather than depriving them from that test.
Wonderful. So very prudent point, and probably the second important take-home message for today is that we need to work the patient up in detail at the very beginning itself and look for avenues wherein we can fit this patient for all the best possible available medications. If not out of pocket, then maybe other scenarios such as clinical trials, which are being conducted at various centers at this point in time, both in Rajasthan and in the rest of the India also.
Even
So,
Pulkit, tomorrow patient may ask us why you did not do that. No. So even to all the like Chiranjeevi scheme, also I asked them that IU based treatment is available in most solid tumors. So
So
I
I
think
said, sir, I do MS. So I said, sir, I do MSI testing, which
huh,
is the basic thing I need for a IO. So that I do.
right.
I'm
Pulkit
not
was
doing
on the right side of
TP53.
the line, sir. Probably I was on the wrong side of the line and I was not doing it. So tomorrow onwards, I am going to change my practice. Pulkit
So
already is doing
yeah,
that.
MSI I'm doing, sir, and some of the pathological lab along with the benefit of some companies, they are free also. Some
Yeah.
of them are doing with a very lesser. So but I'm not doing TP53 and all those other very rare big mutations. I'm not doing that, sir. That's it.
Actually, there are two scenarios here that we are talking about. One is the ideal scenario, and one is the practical scenario. So, ideally, it is recommended that all tests be done for data collection, all markers be done for future data collection in both the early stages as well as advanced stages. But practically, definitely, we can do things according to our resources, but counseling of the patient is important so that they don't tell us later that you haven't advised these things, or we may, because that prognosis will depend on many of these markers.
We are dual classifiers. So because if we don't do the markers, we won't be able to know which of the markers actually takes precedence over the others because of the dual classifiers.
So that is for data collection purpose only, mostly, because like Dr. Pulkit said, yes, for IO we do need only MSI for practically treating, but yes, we do have to have things in the results in our armamentarium for future outcomes also, I think.
So far, if we kind of summarize this particular discussion, one is that there is need of improvement in the care by adding better molecules, and probably those are immuno-oncology molecules. So to check for eligibility to understand the biology of the disease, we need to do extensive biomarker studies right at the beginning, so that we understand what is the biology and what best possible treatment options can be offered. Thankfully, now at this point in time, there are multiple options available in the both first line and second line setting. But now this availability of multiple option further perplexes our choices and our treatment landscape. So let us discuss this on a case scenario basis, that a 62-year-old female presented with a stage 4B endometrial carcinoma, and she has been previously treated with paclicarbo in a adjuvant setting, and she developed progression after 10 months, and she has symptomatic lung mets also. She underwent molecular profiling, and which told us that she is deficient MMR with MSH2 and MSH6 loss, and this was confirmed by an NGS. She has a good ECOG performance status of 1. The organ functions are all healthy. So now my question to my learned medical oncologist panelist, starting from Dr. Lalit Mohan Sharma sir, is first question, sir, would you like to go ahead with what is your first line strategy? What molecule would you like to use here, sir?
So first thing, since she's symptomatic, so in addition to IO, chemotherapy will also be used. And like based on the available data, this dostarlimab remains one good option. Of course, we have used it less, but the science says more, the Garnet trial and others, Ruby and Garnet, they say that this could be a better molecule. Of course, Pembro also is there, and rest all is also there.
So, if I may ask, sir, any particular reason for leaning towards dostarlimab and say not pembrolizumab, who has been in the scenario for a longer period of time, more data?
So, if we see the overall outcome, then probably the dostarlimab scores higher as compared to the others in terms of the data. But if you see the extensive usage, then Pembro we all have used most commonly. But again, it remains difficult at this point, like to be very categorically saying that which we will be using. It depends on many factors, but hardcore, if you take the science part, probably the dostarlimab scores higher, and anybody can add to that.
So, if I may ask Dr. Pulkit, first, your take on immuno-oncology drug alone, monotherapy versus combination, what would be your choice in this particular case?
So I agree with sir that chemo has to be added in view of the symptomatic burden. But I'm not sure a 10-month of DFI after paclicarbo would I would like to re-challenge paclicarbo, because the data of dostarlimab is majority is with paclicarbo. So I would like to use a systemic agent, but depending on what kind of symptoms or side effects patient has previously from paclicarbo combination. So might I would not repeat that paclicarbo.
Performance status, no organ function dysfunction.
Yeah, so I would definitely use chemo plus IO, sir, and as sir has said that the Kaplan-Meier graph itself is a big indicator of the better separation of the curve and good PFS OS data we are having with dostarlimab. So I would like to go with it, since the cost is almost similar because of the different schemes we have. So I would like to choose dostarlimab with systemic therapy in that.
So, Dr. Asim Samar, your take on that? Okay, probably he's not there. So, one thing which we would like to bring to notice of all our listeners is that there are multiple molecules available at this point in time. Second is that in patients who are MMR deficient, there is option of both monotherapy and combination therapy. And third thing is, as very well put out by Dr. Lalit Mohan sir, when the patient is symptomatic and you are looking for a better and early and overall response, you would probably like to add chemotherapeutic agent to reduce the load of the disease, improve the symptoms early, and once we have achieved that, probably then put the patient on immuno-oncology drug maintenance. Did I put it right, sir?
Yeah, I think sounds good.
Sir. So at this point in time, if we talk about guidelines, the guidelines currently are recommending various combinations. One combination at this point in time in the first line setting is a chemotherapy skeleton of paclitaxel and carboplatin along with dostarlimab in this setting. Second is carboplatin paclitaxel along with pembrolizumab, but these the recommendation here is to avoid this in the carcinoma sarcoma setting. And
Dr. Lalit Sharma, sir, sorry to interrupt you. We request you please conclude your panel in next 2 minutes.
yeah, sure, why not? So third option which we have is the same skeleton along with durvalumab, but it has shown data in the MMR deficient setting only. So the last and final question to both my medical oncology panelists: what about in the MMR proficient setting? Does your choices change, sir? Dr. Lalit Mohan Sharma, sir?
In fact, there is more data of Pembro probably for that in your last slide you have shown.
Sir. And would you like to consider ledmoritalib along with that upfront itself or in the second line setting, sir?
In the second line only we use it. Second line means post, like on the relapse setting, stage 4 disease. If the patient is very much stable, then delmartinib plus pembrolizumab remains one commonly used option. If patient is symptomatic with metastatic, then of course chemo partner will also be there.
Okay. And last and final, Dr. Pulkit, your take on the patient who has already been introduced to IOs, and when these patients reoccur or progress, what's your take on the further IO therapy?
So obviously for the second line recurrence, I would like to add first second line systemic therapy to cut down the symptomatic burden. But yes, you have already shown the data for re-challenge with dostarlimab. So given the possibility, no other issues, I would like to re-challenge if patient is MSI high and is indicated. So I would like to re-challenge with it if there is a possibility to do that for sure with the second line chemotherapy, of course.
And the last and final scenario wherein initially the patient presented and we did molecular profiling, and the patient was found to be proficient MMR and MSI stable. So now if this patient reoccurs after 2 to 3 years, would you like to rebiopsy this patient?
Yes, definitely. Rebiopsy is always
Yes.
advocated because many times the receptor profile changes. I think even in about a lot of patients, at 20% or so, it does change. So MMR can express or MMR can become deficient. Even estrogen receptors are lost many times in the second, this thing, about 10% cases.
Ma'am. So, to summarize the whole panel discussion, probably the take home messages are: one, all the patients should be profiled for their molecular status at the very beginning itself. Patients should be offered the best possible immuno-oncology drug choices to start with. And in case of even in the recurrent setting, rebiopsies should be encouraged because there are always chances that the patients might change their molecular profile in the recurrent setting. Thank you so much, my learned panel, for that wonderful insight into the complicated scenario. Thank you, organizers, for giving us this opportunity. I would like to hand over the proceedings to the
Thank you, Dr. Lalit, and the organizers, and Dr. Asim. Thank you all.
Thank you, Dr. Sim, for enlightening us with the milk strategy. Also, that was very, very new.
I think, Dr. Lalit Mohan, we can do one study on this, milk strategy.
We will talk now. Let us move forward because in the interest of time.
Okay, yes.
Thank you so much.
Thank you, everyone, sir. Thank you. Thank you, Dr. Lalit Sharma, for moderating the panel very nicely, and all the panelists who has given their input is wonderful and commendable. So I would like to thanks to Dr. Ranu Patni Madam, Dr. Lalit Mohan Sharma, Dr. Pulkit Nag, and Dr. Apurva Tag. Thank you very much. Now we will move to our second panel discussion. Which will be moderated by Dr. Tarachand Gupta. He is Senior Consultant in Medical Oncology Department, Mahavir Cancer Hospital and Research Center. And his discussion will be on the management of the advanced ovarian cancer. So will be handed over to Dr. Tarachand Gupta. Yes, Dr. Tarachand.
Sir, you're muted, sir.
Unmute yourself, Tarachand.
थैंक यू बॉस। देखो बॉस, मैं हमेशा चुप रहना चाहता हूँ, इसलिए मैंने अपने आप को म्यूट कर रखा था। लेकिन लोग चाहते हैं कि मैं बोलूं, तो मैं बोल रहा हूँ।
Actually, management wants some people to speak and some to be silent. So you are in the speaking list.
पर तारा, आप घर में थोड़ी अभी तो बोल सकते हो। अभी घर में तो मानते हैं कि सभी की आवाज बंद हो जाती है। अभी तो बोलो दिल खोल के।
बस आपके सामने कौन बोलेगा सर? चले। So my panelists for today's discussion are Dr. Snehapreet Kaur, consultant in medical oncology, JNU Hospital, Jaipur. Dr. Satyankar Gupta, senior consultant medical oncologist, American Oncology Institute, Jammu. Dr. Satya Saran Sarangi, consultant medical oncologist, BLK Max Super Specialty Hospital, Delhi. Dr. Mukesh Kumar Jandu, consultant medical oncology, Sarvodaya Multi Specialty Hospital, Hisar. And Dr. Pranjil Mandloi, consultant medical oncologist, IOCI CHL 114 Hospital, Indore. So I think अटेंडेंस फुल है ना, मतलब है ना, मॉडरेटर की तो है अटेंडेंस, बाकी सब कंप्लीट ना, यस सर ना चलेगा। तो डॉक्टर असीम इज देयर। अभी है ना, मतलब जो है ना कि अपन जिस पेशेंट की बात कर रहे हैं, वो कह रहा है कि यार बोले, मतलब है ना, बस आप तो ट्रीट करो यार, है ना, बताओ मेरे को क्या अच्छा है। वो बहुत पढ़ा लिखा बंदा है एंड लेडी है, मतलब ना बहुत अच्छा पढ़ा लिखा लेडी है। तो अपन उसलिए उसके बारे में बात करेंगे हमेशा आज पढ़े। सो टू स्टार्ट विथ yes. So slides are provided from GSK, but I have done some kalakari here also. So we are discussing this. So as we know that these are the you can say approvals for the first line maintenance PARP inhibitors, different approvals. So we are going to discuss first case. This is the 50-year-old female presented with the typical symptoms of ovarian cancer with abdominal discomfort, bloating, satiety, new onset constipation, and an intense weight loss with a good performance status, and patients is under hypertensive drugs for the 10 years. So ultrasound revealed the ovarian mass, a good size, with the PET scan done that was peritoneal mets 2, not other specified, and 2 in number beyond pelvis with largest size of 3.2 centimeter. Mets observed in 2 retroperitoneal lymph nodes, and biopsy suggestive of high-grade serous ovarian carcinoma. So, to start with you, so this is staging, I think, FIGO 3C. Are you agree? Sneh,
Yes,
please.
sir. Yes, sir. Yes, sir.
So what is the next here?
Sir, we will discuss this case in multidisciplinary team with the surgical oncologist and to look for if the cytoreductive surgery is possible in this case or not. So there are various criteria on which the surgery can be done. Initially, we use the Nelson criteria. But in stage 3C, yes, we can definitely go for the upfront surgery with discussion with the surgical oncologist. Or we can also go for a neoadjuvant chemotherapy in this case also.
Dr. Satyankar Gupta, how do you decide for the cytoreductive surgery in ovarian cancer? Is there any criteria or any personal choice?
So basically, a multidisciplinary tumor board discussion has to be done, and the radiology, the CT scans have to be reviewed, and the criteria, as Madam said, Nelson's criteria is there. Mainly, it is the bulk of the volume of the disease, disease burden, and the performance status. So if the surgeon is, capable of achieving R0 resection, and there is no disease in the upper abdomen or root of mesentery, then and patient has a good performance status and no significant comorbidities, then I think the patient should be, taken away straight away for an upfront surgery.
So, Dr. Mukesh Jandu, I think you are agree. America, if you you are disagree or agree with these points of Sneh and Dr. Satyankar?
Yes, sir, I agree with the point
So,
of
what is your neoadjuvant versus adjuvant therapy, and how do you decide for what factors decide your neoadjuvant or adjuvant treatment? Mukesh.
Yes, sir. Sir, based upon the key patient is disease is resectable or not, depend upon that we will choose neoadjuvant
So,
chemotherapy.
surgeon is saying that you go ahead with the neoadjuvant therapy because the R0 resection or optimal surgery is not feasible. So, which factors drive you for the neoadjuvant therapy? What to use, how many cycles, and how?
Sir, we will go for the 3 to 4 cycle of neoadjuvant chemotherapy followed by reassessment for the interval cytoreductive surgery. And before that, we will go for the biopsy and the BRCA testing and all that.
So, Dr. Satya Sadhan Sarangi, are you agree with Mukesh for the neoadjuvant treatment that he is deciding for the paclitaxel carboplatin?
Yes, sir. So the standard regimen is a combination of taxanes and platinum that we use. The only thing is, if a lot of patients in my practice, they usually come with ascites and a poor nutrition status. So I usually start with a Mito 7 protocol of a weekly paclitaxel at 60 milligram per meter square and carboplatin AUC. And as the GC improves, I switch back to the 3 weekly regimen. And obviously, if there is any kind of ascites or pleural effusion or stage 3C and above disease, there is a general tendency to use bevacizumab with it.
So, is this logical to use bevacizumab or data-driven, or it is personal choice in neoadjuvant setting?
Sir, it's I won't say there is no hardcore data in the new adjuvant setting, but extrapolating it from the adjuvant setting, the GOG trials and the ICON trials, we have seen those patients with ascites and pleural effusion. They respond at a much faster pace when we add bevacizumab to it. Only thing that we take care of it is we do not usually give it if, let's say, if we are planning surgery after the third cycle, then we try to omit it in the third cycle. We just give it in the first 2 cycles only. And similarly, subsequently, after surgery also, we wait for 1 month.
So, Dr. Pranjal Mandloy, if the patient is having ascites, then you think that the bevacizumab is good for the neoadjuvant chemotherapy?
Yes, sir, I agree with this because it helps clearing ascites faster. And yes, I agree with sir that I omitted in the last cycle. Also, I would like to mention that I tend to prefer 7.5 milligram dose rather than 15 milligram per kilogram dose because it is better tolerated with the patient.
So, Dr. Esne, are you agree to use bevacizumab in neoadjuvant setting or in adjuvant setting?
So in neoadjuvant setting only with the ascites or pleural effusion, because as previous speakers has told that it will lead to the early clearance of the ascites or pleural effusion. So in neoadjuvant setting, in first 2 cycles, bevacizumab can be used. But in adjuvant setting, first we do the markers like BRCA1, BRCA2. If these are positive, then we can omit bevacizumab in the later lines of therapy in the adjuvant setting also.
So this was the GOG 218 trial that shows the PFS benefit in if you are using adjuvant bevacizumab, and but the OS was not there. But yes, ICON 7 was positive for the use of bevacizumab for 15 months if it was the pleural effusion or the more than 1 centimeter residual disease. Although, yes, this is a clinical practice or this is the common practice to use bevacizumab, but still ovarian cancer is so good to clear the ascites with only the chemotherapy alone only, in neoadjuvant setting. And I think the trial name I am not able to recall, that was, I think, negative for the bevacizumab we are using in neoadjuvant setting. So clear. So now we are moving for the next scenario. So Dr. Satyankar, which biomarker do you test in ovarian cancer patients?
So, sir, two biomarkers have clearly shown their prognostic and predictive value. That is HRD and BRCA testing. So, apart from then, PDL1 is upcoming, but then no established data to support that. So, HRD and BRCA, and that too on the upfront biopsy, not on the intermittent cytoreduction sample, because there are studies. I mean, there was discussion in many forums that after you give chemotherapy, at times you achieve a CR also, 20% cases. So you should do these two biomarkers in the upfront sample only.
Okay. Dr. Satya Sarangi, which testing technology do you use for these biomarkers, HRD and yes, that means BRCA1, BRCA2, and which sample do you use for the this biomarker testing? Yes, it is correct that now, as of now, there is no value of PDL1 or MSI in at least settings where we are planning for the curative intent.
So for BRCA, for germline BRCA, we usually go for the liquid, the blood sample only. And for HRD, we are doing it with the tumor tissue only. And till now, I have only been able to use the coupon-based testing. I have not used the Myriad original one.
You are not using original mind. So, Dr. Mukesh Zandu, how do the biomarkers impact your the treatment choice?
If patient is either germline BRCA positive or HRD positive, in those cases, we can predict the magnitude of benefit from the inclusion by the PARP inhibitor in the adjuvant setting or maintenance settings. Sir.
Okay, so Dr. Pranjal Mandla, it is okay to use in all stages the PARP inhibitors, or should we select?
Sir, in my practice, I use it in the stage 3, stage 4, mainly in the stage 3, stage 4 BRCA or HRD positive patients.
This patient underwent germline BRCA testing and HRD testing, and the germline BRCA1, BRCA2 was negative and HRD was positive. So is this information sufficient to decide on next line of treatment, Dr. Satyankar Gupta?
Yes, sir. It is adequate.
So it is adequate to use, and we are not bothered that if it is NACT or any residual disease, Dr. Snebri. Would you like to see the patient has received NACT or not, or patient having residual disease or not for the use of the maintenance therapy based on this information, or would you like to use the another information?
Yes, sir. If it is a complete response and partial response in previously resected patient having suboptimal reduction, so this will help in decision making. But if there is progressive disease biochemically or radiologically, then we need to use the second line of therapy in these type of cases. In these cases.
So, rightly pointed out, the response to the platinum is the key in the first line setting, at least. So primary cytoreductive surgery was done. There was PET-CR, platinum doublet given for 6 cycles. Bevacizumab not given due to the accelerated hypertension. Our patient had the partial response to platinum. I think it should be a complete response because there was no residual disease. So I think there is some clerical mistake. So choice for maintenance therapy, if the patient is having response to the platinum therapy, first of all, if we are going that the patient has achieved PET-CR and pathological CR, patient is BRCA1, BRCA2. If patient is BRCA1, BRCA2 positive and HRD negative, and so Dr. Satyankar Gupta, will you use the PARP inhibitors in this case if the patient has achieved the PET-CR after the NACT and the patient is BRCA positive, HRD negative?
Yes, I would tend to use only olaparib.
You would like to use oral aperitif. So, Dr. Satya Sarangi, I think there is solo one trial that especially mentions some high risk criteria and low risk criteria. So, can you explain those where to use this PARP inhibitors or not?
Sir, like we have already discussed this also, like if there is like in the stage 3 to 4 CA ovary patients and those who are having a response to the platinum therapies and is BRCA negative but HRD positive. So here I think definitely we have to use this PARP inhibitors because we know that the CA ovary patients are tend to prone for early relapse even if they are complete responsive disease.
So I think we are moving again. That the Solo-1 trial clearly mentioned that if the patient has achieved the PET-CR, then it comes under the low risk category. So there are no benefit of in BRCA, even BRCA positive patients of the olaparib. There is magnitude of benefit is very less. So this is the ESMO guidelines on systemic therapy in advanced ovarian cancer. That if the patient is BRCA1, BRCA2 mutated, then olaparib, niraparib are there, and olaparib bevacizumab, we have used the bevacizumab along with that. If the patient is HRD wild type and HRD positive, then niraparib is the right choice. If we are have used the bevacizumab, then HRD comes according to the Paula-1 trial, and BRCA1, BRCA2 and HRD negative, again the bevacizumab or niraparib is the right choice according to these ESMO clinical guidelines. So these are some clinical data also that are suggestive of GOG 218, Paula-1 and Prima, where the maintenance therapies were used in GOG 218 bevacizumab, Paula-1 Bolabev, and Prima niraparib as per placebo. So treatment discontinuation rate is the least in the Prima trial, that was of the niraparib in ovarian cancer. So these are the NCCN guidelines which are also recommending the different that stage 1 there is no PARP inhibitors are mentioned, in even stage 2 to 4 if there is a CR then it is to observe, or olaparib can be given in category 1, bevacizumab plus olaparib, and the patient is a BRCA1, BRCA2 wild type or unknown, then platinum based chemotherapy CRPR, then bevacizumab plus olaparib or niraparib is the choice of the therapy. So niraparib 200 milligram already initiated. So case 2 that the patient 60-year-old female, abdominal pain, bloating, weight loss without any family history of malignancy. CT scan revealed the large mass in bilateral ovarian tissues. Multiple masses were observed on both sides of the pelvis with the largest cross-section measuring approximately 7.6 into 6.2 centimeter. Multiple masses were observed in the peritoneum and omentum. CA125 is moderately high with the laparoscopic biopsy suggestive of high-grade serous adenocarcinoma of ovarian. So patient is diagnosed as the stage 4B high-grade serous adenocarcinoma of the ovary. So Dr. Mukesh, will you give neoadjuvant therapy in patients before debulking surgery?
Yes, sir. To decrease the morbidity from the surgery, I will go for the upfront neoadjuvant therapy.
Yeah, correct. Because if we are already curious about in the stage 3C, then yes, stage 4B actually demanding, because the optimal cytoreduction or the R1 resection is the key, at least. So the safest is the R0, but yes, if still we want to use the R1, then NST may be needed. So patient received neoadjuvant paclitaxel carboplatin 3 weekly into 3 cycle. Interval debulking was done. Post-surgery adjuvant paclitaxel carboplatin for another 3 cycles. And now the molecular testing is done, the BRCA negative and homologous recombination proficient. So Dr. Pranjal, what maintenance therapy will you give this patient now?
So the patient is advanced stage to begin with, and post interval debulking, I would like to go with PARP
The
inhibitor along
treatment is
with
complete now.
bevacizumab.
The treatment is complete. All the 6 cycles adjuvant completed. The molecular profiling is BRCA negative and HR proficient.
I would like to go with olaparib plus bevacizumab in this case, if there are no medical contraindications like accelerated hypertension or varicose or
Yeah,
other
even if
things.
the patient is molecular testing negative, right?
Yes, sir.
Okay. So Dr. Isne, what is your take?
Yes, sir. In this case, I would like to add bevacizumab and niraparib in this patient. PARP inhibitor should be given in this patient because of advanced stage 4B, and molecular markers are negative. So PARP inhibitor along with the bevacizumab niraparib.
Oh, so you are preferring niraparib? Any reason for
Yes.
the over the olaparib?
So mainly in Prima trial and Prime trial, niraparib has shown the PFS benefit in these patients, which are negative for molecular markers. And bevacizumab, like in 218 in stage 4, they have shown the 10-month survival benefit in mainly in stage 4 disease, not in stage 3 resected patients. So either bevacizumab or niraparib.
I think this is the basis of SNA's decision that the PARP inhibitor in HR proficient population, where the PFS was in favor of niraparib, either PRIMA trial, which was the global trial, and the PRIME trial, which was the run in China only. So other are having that PAOLA-1, olaparib, BELAS, BEV, hazard ratio is poor in support. So response to niraparib in patients who received the neoadjuvant chemotherapy is excellent. Difference in PK activity of various PARP inhibitors, that is also in favor of the niraparib, and difference various PARP inhibitors. This is the PARP inhibitor and secondary targets of PARP inhibitors. Olaparib, PARP inhibitor, PAR1, PAR2, and tankinase 1 by 2, 1 and 2, and niraparib. Also, the but tankinase is weak with the deoxycytidine kinase, and rucaparib also hexose 6-phosphate dehydrogenase enzyme is degrading enzyme. So what are the precautions particularly related to drug-drug interaction we usually follow before initiating PARP inhibitor therapy? These are the some metabolism of the PARP inhibitor molecules, where the niraparib is metabolized by the carboxyl esterase, while other are the CYP inhibitors. And these are the extent of CYP involvement. So as it is not metabolized by the CYP, so the niraparib is not dependent on niraparib. So drug-drug interaction is also very low with the niraparib. And excretion route is nearby same. For the olaparib and niraparib, it is 50-50 urine and feces. But for the rucaparib, it is mainly excreted by the feces only. So now we are taking choice by choice. So first thing, Dr. Satyankar Gupta, if HRD positive but no bevacizumab was given and BRCA is wild type, then which PARP inhibitor will you use if we are having the clinical scenario to use the PARP inhibitor?
So both of them can be given olaparib alone or niraparib alone, because patient is BRCA negative but HRD positive. So HRD positive tend to derive benefits with either of them, depending upon the
So
practice and the confidence that the clinician has.
yeah, you may be correct, but the where the drug olaparib is coming in HRD positive patient, that trial is the PAOLA-1, where the bevacizumab was also given along with that. Otherwise, for the BRCA1, BRCA2, it was solo one trial. So
Yes.
this was the niraparib here only that was tested in both scenarios, as Dr. Snehpreet earlier elaborated. So Dr. Satyan Sadhan Sarangi, if the HRD is negative also and BRCA is also negative, so what PARP inhibitor will be of your choice?
Sir, I think theoretically we can use both niraparib as well as rucaparib also. Rucaparib, although the approval is pending, but the Athena trial is showing irrespective of HRD status you can use. So I will choose niraparib in first option and second option rucaparib, but no olaparib here.
Okay. So correct, yes, this is also niraparib. So Dr. Mukesh Kumar Jandu, if the patient HRD is unknown or unavailable, suppose that the patient is saying that many some you can say ki MP fund or MLA fund, but the patient is hand to mouth and unable to do the HRD. So, but yes, from the MLA fund, MRD, or say MP fund, he can avail the drug. So, what will be your choice of PARP inhibitor?
Sir, irrespective of HRD status, we can use niraparib.
So, yes, if there was another, according to that PRIMA trial, also that if the HRD is unknown or unavailable, then yes, niraparib is also the choice. So, if high risk disease is there and we are not going to use the bevacizumab, and we are giving the as per the paclitaxel carboplatin, and patient post NSCT there was the residual disease, then Dr. Pranjal Mandloi, what will you use in a maintenance PARP inhibitor?
In this, sir, in this setting, single agent niraparib would be the choice of the agent.
Yes, again, those the trials also
For
support that if the patient is high risk, especially that was decided according to the NSCT or suboptimal, and if there is HRD positive only, and then the niraparib is again the choice. तो ऐसा नहीं है कि हम ओलापेरिव से बेईमानी करेंगे, हम यहाँ पे ओलापेरिव की भी बात करेंगे. So niraparib versus olaparib biomarker requirements. This is the summary slide for that. That the niraparib works in all comers, HRD positive, HRD negative, and HRD unknown. And the olaparib is best in BRCA mutated or HRD positive, but along with the bevacizumab. High risk patients, stage 3 residual, stage 4 NACT, niraparib is strongly preferred, prime evidence. Dose strategy, as there the niraparib individualized starting dose 200 milligram was the body weight less than 77, that was tested in the prime trial, so it was okay to use and with the equal effect, while it is olaparib where the fixed dose combination we have to use, though if we are able to use the adequate dose, then we will be able to have the results. Along with the HR proficient, niraparib offers the clear benefit and olaparib has the minimum benefit. With bevacizumab combination, niraparib you can even have, if you have used the bevacizumab during the chemotherapy or the patient now you want to use the monotherapy, then niraparib is the clear cut choice. And if we want to use the bevacizumab, then olaparib is the choice with the bevacizumab. This is the flow chart. When to prefer niraparib over the olaparib, I am talking only that frontline maintenance PARP inhibitors, BRCA mutation positive, olaparib. If no, then HRD positive, yes. Using bevacizumab, yes. Then you can use, sorry, it is olaparib, not the niraparib. But if not using bevacizumab, then the niraparib. And if HRD is also negative, BRCA is also negative, then the niraparib is the choice. So, Dr. Pranjal, in the last, so please summarize where will you prefer niraparib over the olaparib?
Niraparib can be given to all comers, like those who are HRD negative or high risk disease, or where we cannot give bevacizumab. In those cases also we can give niraparib. Then there are patients which are HRD positive but BRCA negative. Niraparib would be, we will prefer niraparib. So these are the certain places where we can use niraparib. Also, I feel it is better tolerated than olaparib.
मुकेश, तुम यार बड़े स्मार्ट लग रहे हो ना कोट वोट पहन के, तो थोड़ा सा यार यू प्लीज ऐड ऑन ना सम लाइट थ्रो, थोड़ा टॉर्च जलाओ.
Sir, basically in all those cases where BRCA is negative, we can use to prefer for niraparib. In BRCA positive cases, I would like to prefer go for the olaparib.
Sneh, your choice.
So
You are
similar,
also looking smart. चलिए.
so similar views on this. In HRD positive and BRCA negative, we usually prefer niraparib. But if BRCA positive, then olaparib is the first choice.
So I think GSK will be happy that the people are ready to use if the patient is having unaffordable, like here we are seeing that in Rajasthan as RGHS patient where the drug is also available, but for the test patient has to pay. And if the patient is the peon but in RGHS and unable to afford the test cost, then niraparib may be the choice. If still there is a residual disease or high risk disease, then on the HRD negative, sometimes patients are not able to take the bevacizumab because of the drug-induced hypertension during the chemotherapy treatment. So at that time, yes, olaparib is also a good choice. Oh, sorry, niraparib is the right choice. So now I conclude my session, and Sneh, please log in with your name only, not the Gunur. So it is good to see.
Thank you, sir.
Thank you, Doctor. Thank you, Dr. Tarajan. For a nice, actually, moderation. And thank you all the participants, Dr. Mukesh,
Thanks.
Dr. Snehapreet, Dr. Satya, and Dr. Satya and Dr. Pranjal. Actually, everyone was good. And thank you, Dr. Tarajan, for making more point clear and which setting, which drug to be used in a very tricky way. Now I would request for the next session, Dr. Abhishek Charan to join. And Dr. Abhishek will be speaking on IV iron in 2025, management of anemia, cancer-related anemia. So going good to great, where to use the IV iron. So this session is sponsored by Zydus. Dr. Abhishek Charan, over to you.
Thank you, sir, for the opportunity. Good evening to everyone.
Good
So
evening.
I'll be speaking today about the iron deficiency anemia in cancer patient. Can we have the slides, please?
Yes, sir.
Yeah. So, yes, next, please. So coming to the anemia, first of all, so India, as we all know, is a developing country. So deficiency, nutrition deficiency is part of all the age group and mainly in the children's, and it has become a part of the society also. So even as we find in India, up to 40% patient may have iron deficiency anemia. And this is more common in the regions which are underdeveloped, like in Bihar, Madhya Pradesh, and this has been studied widely and has been reported. So up to 41% of the children under 5 are iron deficiency anemia, 24% are in school age group, and 28% are in adolescent. So it is a part of the society because of our dietary habits and restriction and the limited resources. The anemia is quite widely prevalent. So this gives us the background that already we are deficient and already the population is anemic. So over above that, if the patient has a cancer, so the chances of developing iron deficiency anemia in Indian patient is quite high as compared to the Western patients. Next, please. So iron deficiency anemia is the most common cause of anemia. This has been reported also in various studies and found to have that iron deficiency anemia is the most common cause. Then there are other causes like anemia. There may be blood loss due to, menstrual loss may be there, or there may be surgery, gastrectomy, or there may be decreased absorption due to ulcers. There may be a lot of causes. The most common causes mainly nutritional in India, and which leads to iron deficiency anemia. Next, please. So, as we all know, anemia is a part of all malignancy, including solid and hemat, and we widely see in our OPDs that at least 80 to 90% of our patients will be anemic, and it will progress after giving chemotherapy, and if we combine radiation along with that, that will impact your skeletal system. So the chances of developing anemia is even more, and it progresses also. Next, please. It is associated with all malignancies and mainly seen in GI malignancies and pancreatobiliary, but it is common in hematological malignancies as well and covers almost all malignancies and all age groups. Next, please. So iron is how the iron is absorbed and all that. So what I like, iron is mainly it is around 4 gram in our body, and 50% of the iron will be stored in your three organs. That will be spleen, liver, and bone marrow, and remaining 50 will be in the circulation. I mean, it will be either the part of your RBCs or muscle system. So there is no active form of the iron in the body. There may be two components of the iron, ferrous and ferric, and they will keep circulating, and this will be required to bind your myoglobin and carry your oxygen, and all that process will be required. And there is no definite way of excretion of iron from the body. It may the it may be not be absorbed properly from your intestine due to any reasons. You may have any intestinal issues, infection, or surgery, or ulcers, or anything, or there is no proper way of excretion. So mainly it is lost either in the form of decreased absorption or menses, or it can be also lost through your sweat also. So generally we require around 10 to 20 gram mg of iron per day. Next, please. Yeah. So that's what I was mentioning, that through the diet, the iron will come into our system, and most of our iron is 50% is stored in your these three organ, and 50 will be in circulate. Next, please. Already covered this part. Yeah. So this is the mechanism. The diagram is showing an intestinal absorption of iron, where DMT1 is the regulator which increases the iron, and ferritin is the form where it is stored in the iron. So, and ferroportin is your channel, excretion channel, from where ferrous is excreted and it's converted into ferric, which then circulates in the body with different proteins and transfers your myoglobin and other things. Next, please. Yeah. Next, please. Already covered. Next. Yes. So this is a typical mechanism of how iron is absorbed in the intestine, how it is converted to ferritin, then exported out from ferroportin and is stored in various organs, and it combines with transferrin also. So this is the way iron is functions in body. So hepcidin is one of the molecule which is, I mean, it is an inflammatory marker, and it is mainly seen in your any acute or chronic inflammation condition where you may have infection or you may have malignancy where hepcidin will increase. So increase in hepcidin will lead to decreased iron absorption. This is a mechanism because then hepcidin reduces your formation of ferrous to ferric conversion and your iron absorption will be reduced due to hepcidin. And hepcidin increases in malignancy too. So in a way, hepcidin is a very important regulator for your iron hemostasis, and it plays even a bigger role in malignancy because hepcidin will be quite high in your malignant patient. Next, please. Yeah, next, please. Already covered. Next. Hmm. Next, please. This I have already explained in simpler word. Next, please. So mainly in iron anemia or what we encounter in our, there is iron deficiency anemia, there is anemia of normocytic normochromic anemia, or there may be functional iron deficiency anemia. So serum ferritin. So as we studied in our medicine, there are four. Investigation which we do for IDA. So first is your serum iron, followed by your serum ferritin. Serum ferritin is the most specific investigation which gives us the idea whether the patient is really iron deficiency anemic or it is functional or it is due to normocytic or any other bifunction reason. And then comes your transferrin saturation and TIBC. So other than TIBC, everything will decrease. Your serum iron will be low, your serum ferritin will be low, your serum transferrin saturation will be low, but your total iron binding capacity will be increased in iron deficiency anemia. So in true iron deficiency anemia, which is your ferritin will be quite low. It will be low as low as 15 nanogram per ml, and sensitivity is quite specificity for this is quite high, 99%. And if ferritin is less than 45, in that case also it will be considered as deficient, but then it will be functional. So below 15, it is a true IDA, and from 15 to 100, it will be like functional IDA. Next, please. So this is the spectrum which I was saying that as we go from your transferrin saturation, ferritin, and your iron studies will be low. And as we go through this, your spectrum towards the right, we'll see that your T set will be increasing, your ferritin will be increasing, and this shows the trend towards it. So they all move together, and most of the patients will have your T set below 20%, ferritin below 30 nanogram, and this gives us the idea that patients are truly IDA. Functional iron deficiency anemia is the one where your iron is available, but we are not able to utilize it to form your RBCs. It may be due to hepcidin blocking it, or it may be due to the old age or inflammation that your iron is not able to get released from the your stores and it is not available for the production of RBC. So that the iron is there, but it is not available, is labeled as functional iron deficiency anemia. In that condition, it is in such condition it is labeled as functional IDA, and here the T set will be around 10, 20 to 50%, and your ferritin will be around 30 to 800. Generally your ferritin will be high around 50, 80. So this is a marker serum ferritin. If really low, then it is IDA. If it is 30 to 100 and still a patient is anemic, then it goes into a direction of functional IDA. So this gives us the idea how to treat. Because if functional IDA is there, your iron is not getting absorbed and not getting available for RBC production. So your oral iron supplement won't work in this case. Functional IDA can only be corrected through your IV iron. And in case of your true iron deficiency anemia, your even oral iron supplements or your IDA, your IV iron supplements or whatever ESA you give, they all will work in your functional is absolute iron deficiency anemia. But functional only real IV iron supplement can work. Next, please. Next, please. Yeah, already covered. Yeah. So mainly, yeah, next, please. So this is how we evaluate our patient who present to us in OPD. We assess the HP first of all in our CBC. We see whether the HP is below 10 or not. If the HP has a rep below 10, and we need to increase the I mean HP rapidly because we need to give chemo or we need to start the treatment or patient general condition is quite poor. So rapid and increase can only be due to your blood transfusion. If there is iron, and simultaneously we work up for the cause of anemia also. If there is iron deficiency anemia, or if there is other nutrition B12 or folate deficiency, we work up for that also. So in case I'll be covering iron deficiency in this part. So if there is a true iron deficiency anemia where your serum ferritin is below 100, in that case we should give IV iron, and that should be around 1000 mg in adults. Pediatric it can be 500 mg, but it is ideally given as 1000 mg. It can be given through erythropoietin stimulating agent, but before giving ESA, your iron store should be full. Because if you give ESA and if you haven't replenished your iron, then it won't work because you won't have iron for your erythropoiesis. So better to give iron first and then followed by ESA. ESA agent can be anything. You can do darbepoetin, apopoetin, or whatever you are preferring. It can be given. Though ESA should be used cautiously because they have some side effects like hypertension, thrombotic events, and some studies have quoted also that it may lead to your tumor progression, also decrease survival. So it is debatable whether to use ESA. So it is one tricky thing. But ideally, it can be given. It should be used cautiously, but your iron should be replenished first before using ESA. So if your HB is 10 below 10, ESA is required. You can give it after replenishing your iron. And along with the ESA, in case of functional iron deficiency, and you should also give your iron also that I've already covered. And if there is no iron deficiency anemia, you have normal transferrin saturation, serum ferritin, then in those cases, only erythropoietin stimulating agent can suffice. If your HB is 10 to 11, in that cases, you need to assess again for the iron deficiency, B12 deficiency, and other causes. And we can, if their T sat is below 20 or your ferritin is below 100, if ferritin is below 100, then IV iron is always recommended to give at dose of 1000 mg. One stat dose is good enough to keep your, to bring your HB to at least 1 to 2 gram in next 2 to 3 weeks. Next, please. This is as per the ESMO guidelines. Next, please. So this shows the graph that how history of iron development came. So first came your ferrous, then came your iron saccharide, then came your dextran, then came your prospective first study in 80s. Now it has evolved over a period of time. Then came your sucrose, and now we have all the new agent have come, isomaltoid, ferrum oxetol, and all these new agents have come into the picture. Next, please. So safety, efficacy, and high dose is also covered. Next, please. So I'll be talking about ferric maltose about this because it is one of the newest treatment after FCM we have seen in iron deficiency anemia, and it has a better safety profile and better efficacy as compared to FCM. Next, please. So how it is different from the FCM and other traditional IV irons which we are using? So in traditional IV iron, there is a iron oxyhydroxide core, and there is a carbohydrate shell around it. So it is a shell which is stopping it from reacting and is releasing your iron. So ferric maltose is a complex iron hydroxide and maltose, an iron carbohydrate oligosaccharide that releases iron. In conventional iron, this carbohydrate limits your release of iron as much. So this makes it that amount of iron availability in this FDI is better than as compared to your conventional iron supplements. And this also increases the your side effect profile. Also, it makes it even better because of this composition and this difference in carbohydrate shell. Next, please. So, and one more thing, non-transferent bound iron will be low in your FDI as compared to FCM. So, non-transferent iron increases lot of your issues. It because it accumulates in the tissue, which can lead to endocrinopathy and heart failure. And this was studied in that NTBI was low in your FDI as compared to FCM. So the side effect profile will be better, and you patient will have less likely to have endocrinopathy and heart failure in such patient. Next, please. So innovator versus generic has come, and dissimilar ferric maltose isomaltose formulation in vitro comparison between originator and intended. So it showed that whether simple in vitro test can distinguish the high dose IV formulation, and from the first intended copy of this, it has shown good result and approved in India and Pakistan respectively. Next, please. This is a graph showing the overlaid size exclusion chromatogram for these patients, and it shows the better efficacy and better outcome in these patients. The retention is better, the size is almost same, and showed a good outcome. Next, please. So distinct structure or high molecular weight impurities in all these FDIs was seen, and high free serum iron and high impurities in generic iron, iron isomaltoid was seen. Next, please. So, because of the difference in the carbohydrate shell, the release of the iron is more in FDI, and it is shown in various studies. Also, it is shown in this graph also that mean patient iron need exceed 1000 mg, and it provides that much iron in one shot. So it can be one of the consideration in our patient, and in most of the patient, because of your requirement, because the HP will be around 8 to 10. So your, and if patient is adult and above 40 kg, your iron requirement will go up to 1000 or even 1500. So in such patient, FDI is better recommended as compared to other agents. Next. So it can, though your iron need can be calculated through a Ganzoni or simplified table, and this graph simplified table, it shows that if your HB is below 10, and in patient his body weight is between 50 to 70 kg, in such patient minimum you need to give 1000 to 1500, and if patient is above 70 kg, then your real requirement of iron is up to 2000 mg. What this IM dose is given, it is mainly 20 mg iron per body weight is given per week. So minimum administration time is 20 minutes if you are giving below 1000 mg, and above 1000 mg then up to 30 minutes it can be infused. Next, please. So it offers a fewer infusion reaction as compared to other patient other FCMs वगैरह. So this is one of our I mean concern whenever we were in our MD time also. The infusion reaction was quite common with your sucrose and even your maltose, and yeah, it was less in FCM as compared to other oral other IV sucrose and other agent. But even FCM did had some reaction. I have also seen quite reaction with FCM also. So the infusion reaction is quite common, and it initially helps in initial part of the infusion when the infusion is just started within the first few minutes, because as soon as the drop goes, and the main reason for infusion reaction what we see in our practice was a rate. If your rate is slow, then your infusion chances or infusion reaction will be less, but if your rate is high, then you may see adverse reaction or infusion reaction within first few minutes or even within first few drops. So it was reported to have less infusion reaction in Faro, as compared to your FCM. Next, please. So there was one phosphate program was studied to see the side effect of FCM. As we all know, FCM has quite side effects. Infusion reaction may be there, or hypophosphatemia reaction was there. So it was studied in one phosphate program, and that was considered was part of one of the studies. Next, please. So this was studied in and effects of iron isomaltoid versus FCM on hypophosphatemia in IDA patient. So these two randomized controlled trials were done in America along with one center in Europe. Next, please. So the trial design was whether to assess the FDI versus FCM and to see whether what will be your side effect profile, how the patient will do, what will be the outcome in this. So both patient they were randomized if they were 18 above and on the basis of their iron deficiency. True iron deficiency anemia should be there to give them IV elemental iron. And in such patient, both in the randomized arm, they were given 1000 mg IV. In one FDA, other was FCM, and 500 mg was given or 1000 mg again on day 35 for such patient. So what was observed that HB level increase as per the requirement on day, and they were assessed on day 14, 35 and simultaneously, and the increase in HB was seen in patient in both patient, but it was marginally increase in FDI as compared to FCM. Next please. So HB increase was comparable, but it was marginally better, and side effect profile was quite favorable in terms of FDA as compared to FCM. As we can see on the sequential assessment on day 14, 7, 14, and weekly, then it showed that your HB was more or less comparatively same, but though it was better in case of FDA, but side effect was quite remarkable. I mean, it was quite less in case of FDA as compared to FCM. Let's next, please. So this shows of the fatigue scale score, which improved gradually in your FDI as compared to FCM. Because the patient had lesser side effect, the marginal increase was better in FDI as compared to FCM. So fatigue score was more in favor of your FDA as compared to FCM. Next, please. So pooled incidence of hypophosphatemia, it showed that incidence of hypophosphatemia was significantly lower in your FDI group as compared to FCM group. And the reason behind it was explained that your shell group, your carbohydrate shell, that helps in releasing more iron and that leads to reduce hypophosphatemia in such patient. Next, please. So in this study, it was found that severe hypophosphatemia, that is serum phosphate below 1 mg per deciliter, was 0% in your FDA as compared to 11.3 with your FCM. Next, please. So in this forest chart, we can see the diamond in the both FDI, and in both the subgroup, it was showing that benefit towards the direction is towards the FDI only, and it shows that benefit was available in all the subgroups. Next, please. So FCM induced fibroblast growth factor 23 mediated syndrome. This is 6H syndrome. This was what I was mentioning. This is a common and reported side effect of your FCM. We commonly see hypophosphatemia, high FGF23, hyperphosphaturia, hypovitaminosis D, hypocalcemia, and hyperparathyroidism due to your reported FCM. Next, please. So it was seen that your FCM reported had higher incidence of 6H syndrome as compared to any other IV elemental iron, and the main reason was your FGF23 degradation was less, so it was more increased. Your intact FGF23 fibroblast growth factor 23 was more, so that led to your reduced activation of vitamin D, that lead to increased excretion of phosphate, and that led to further increase in your hyperparathyroidism, and eventually it lead to your severe hypophosphatemia. So this was a proposed mechanism for your 6H syndrome, and it was mainly seen in your FCM, and it was not observed in your FDI. Next, please.
So I'm so sorry to interrupt. We're just a little short on time, so I would request you to kindly conclude in another 2-3 minutes.
Yeah, sure. Next, please. Yeah. So combined effect of the hypophosphatemia that there was reduced kidney injury and bone events in such patient. Next, please. Fracture rate was also reduced because of reduced hypophosphatemia. The infusion reaction with this was reduced FDI as compared to other FCM and other IV elemental iron. Maximum in sucrose followed by FCM and minimum in case of your FDI. Next, please. And next, please. So Fishburne reaction is one of the reported reaction where mild infusion reaction can be taken as infusion reaction, but it is not as infusion reaction. It is a different entity, and that has been reported as Fishburne reaction, where you can continue the infusion, you can just reduce the rate, and you can restart it. Next, please. Next, please. Next. Yeah. So factor increasing your hypersensitivity reaction are almost same, and the severity of your hypersensitivity reaction with FDA were quite low, and this was reported in a pooled analysis by Pollock and Bigger, where 8,500 patients were pooled, and it was found your hypersensitivity reaction was quite low. Next, please. Next, please. Next. So IV iron infusion reaction is the same way we manage it. We stop the infusion, we reduce it, let the patient settle, and then we can restart with a slower or 25 to 50% rate. Next, please. Yeah, next. Next, please. Next. Yeah, already covered. So I've already explained that we need to reduce the rate, and that can cover your. So expert consensus is in that we should use IV iron, and if possible, we should give FDI because it has lesser side effects and better availability, reduce FGF 23 degradation, and it can reduce the infusion reaction with the better fatigue score and better outcome as compared to other IV elemental irons. Next, please. So it in all guidelines also it has been suggested as preferred agent, and your FCM is no more considered as preferred because of your other side effects which I've already mentioned. Next, please. So coming to the message that iron iron isomaltoid is the highest amount of iron available, that is 20 mg per kg. It has greater increase in HB as compared to all other IV elemental iron, lesser fatigue, lesser side effect, only one dose is required, and it has better side effect profile, less hypersensitivity, less anaphylactic reaction, and it does not lead to 6H syndrome, which is one of the major side effect of FCM, which led to your bone and kidney diseases and increased fracture rate. So in eventuality, it is a latest modality, and we should use more. Thank you.
Thank you, Dr. Abhishek, for nice presentation. Thank you very much. And now we'll be moving to the last session of this meeting. And can I share the slide?
Yes.
Yeah. So we'll be speaking on the CAN assist test. Just I will adjust this. Right. So multi-marker test for recurrence risk prediction in hormone receptor positive early breast cancer. And this is the data about the CAN assist test, which we are using very frequently. My voice is clear, no? Okay, so we suppose we got the patient of ER positivity, then we see that it is HER2 negative or not. HER2 test is what positive or not. If it is HER2 negative, then it will be luminal A or luminal B. and if it is HER2 positive, then it will be luminal B. Then our challenge is to just give me a minute, right? So endocrine therapy and chemotherapy only in select cases with high disease burden. Now we need to classify that where we should apply the chemotherapy or not. Okay, goal for prognostication and the hormone receptor positive, HER2 negative EBC. This is the main common topic of interest in this meeting and in this particular topic. Prognostic test should assess the patient risk of relapse based on the intrinsic tumor biology that is beyond what is offered by the current methods, and they should help to patient safety of the patient according to the risk recurrence risk stratification. We have 4 tools till this date: Oncotype DX, Memaprint, Prosigna, and EndoPredict. So amongst them, Oncotype DX is the most famous thing, which earlier we used to use, but after the evolution of this scan assist test and the reduced prices of the test, we are using more frequently the scan assist test. So currently used risk stratification tools are traditionally traditionally we use the various factor like age of the patient. If patient is a younger age group, then it is already high risk. Tumor size, if it is larger, it is high risk. Grade, pathological grade of the tumor, if it is grade 3 or 4, it is high risk. Sorry, grade 3. And nodal status, if any node is positive, that becomes it is a high risk. Some online tools are available which we use to feed the data about the patient age, tumor size, grade, and all that, and then automatically they will calculate the thing. Most famously uses adjuvant online. ISD-based marker, which were very much in the limelight in the last decade, Ki67, luminal AB subtyping, and ISC4. But now they are using their glory, and here is the multi-gene test, which is Oncotype DX and Memaprint. So first is the editorial published in the New England Journal of Medicine, Biology Before Anatomy in Early Breast Cancer. This is the point where you need to assess the biology of the tumor to truly risk stratify your patient. If patient is low risk, then still you need to risk stratify so that you can de-escalate the therapy. So prognostication and optimum treatment planning. You see, if patient is clinically low risk, then you need to precisely assess the risk, because every low risk patient will not survive more. If patient is low risk clinically and some biologically it is high risk, then your treatment may fail and patient may experience the relapse or risk. So if patient is low Ki67, T1, T2 tumor and N0 disease, postmenopausal lady, and if there is a high risk biological behavior of this tumor, how to identify, then we will see further. But in this particular patient who are clinically low risk but biologically high risk, we need to escalate the treatment and we need to give the chemotherapy. And the other side, which is very reverse to it, a patient is clinically high risk but a patient has a low biological risk, then you need to de-escalate. Here comes the role of this particular gene testing. So what are these? N1 disease, premenopausal, grade 3, postmenopausal, grade 3 and grade N1 disease. So this patient, if they found to have the low risk, then we can forego the chemotherapy and give only hormone therapy. So these are the various genomic platform where we can classify the tumor. Oncotype DX use 21 gene signature, Memaprint 70 gene signature, EndoPredict 11, and Prosigna 50 gene signature. These tests are developed by different company in different nations, and they have the data backup also, and they are FDA approved. So widely used tests are Oncotype DX and Memaprint. Oncotype DX use 21 gene signature test, and it is used in hormone receptor positive, HER2 negative, N0 EBC, and the central testing is done. And if the patient are low, they classify the patient in low, intermediate, and high risk. Memaprint is low and high, and Prosigna is again low, intermediate, and high. So the validation studies have majorly in the Caucasian population. Why they are not applicable very truly in our setting is, just a minute, because these tests are validated in the Caucasian population. There is a white race, this population has a higher age of incidence of the breast cancer. They have very small tumor size. The median size is 1.5 centimeter. In India, it is around it is more than 3 centimeter, or sometimes it is 5 centimeter. They have majorly node negative disease, and in our population they have a high tumor size and the node positive disease. So here is the Asian population are underrepresented, and it was only less than 8% patient were the Asians. So future direction is tumor biology such as proliferation gene groups may differ by race, contributing to the noted disparities. Further analysis of the gene groups by race is RX founder will be explored. And this is the effectiveness of the breast cancer recurrence score varies by the races. And they have said there was no significant reduction in the risk of death with adjuvant chemotherapy among Asian Pacific Islander patient with the recurrence score of 26 to 100, or any patient with the score of just a minute, why it is popped in 11 to 25. So ICMR guidelines gave below remark about the multi-gene signature MemmaPrint and Oncotype DX. They clearly said in their Gazette notification that their clinical utility of this kind of signature gene testing, the clinical utility and added value in routine practice is not yet unknown, and there is a very little data in the Indian patient. Recently ISC4 test, that is ERPR, HER2 and Ki67, seems to be provided useful information and is advocated by the NICE in the research. So they said the Oncotype DX and MemmaPrint data is not applicable to Indian population, and instead of doing that costly test, we can use the ISC4 testing. Difference in the breast cancer patient, where we found which kind of patient we found in the Indian and Asian context as compared to the Western patient. We earlier said in the Asian and Middle East patient, they are younger at the onset, a decade earlier compared to the Western woman. They have a high tumor burden, primary node positive disease, symptomatic detection, primary stage 2 cases, more than stage 2 cases. And Western cancer patient are advanced or very elderly patient at the onset of the disease. Most are the postmenopausal. They have a very small tumor burden because they find it early. Primary node positive cases are rare. They are not negative, and screen-based detection happens there because they have a very structured cancer screening program. Our problem is disease onset at younger age among our patient. And just a minute, why this notification is not going? Right. Disease is majority node positive, grade 3 and high risk Ki67. So our need is requirement of the prognostic test. This is suitable for our patient, and this is kind of indigenous test which they have developed. Can somebody move the slide? Okay. Development of the novel proteomics risk classifier for prognostication of patient with early stage hormone receptor positive breast cancer. This was paper published on the Kane assist test. See why ISC can be better tool in the Indian scenario. Why we should not go for this gene-based testing in context of the blocks. Rejections are less in the ISC setting, and direct visualization is yes present, and cellular localization, yes, it is there. Functional statement visualization is there, and confounding effect by the surrounding non-tumorous tissue that happens with the PCR based testing. It is not there in the ISC based testing. So it is more suitable to the Indian context rather than the genomic based approaches. They require actually high end equipments. They are costly also, involve multiple quality control steps to run the test. They require a very different environment so that there should be no confounding factor or the non-tumorous tissue confounding factors. It goes beyond the routinely performed proliferation and hormone indices. So which type of the ISC they involved? They involved 6 factors, 6 parameters: ABCC4, ABCC11 gene, CD44, P cadherin, N cadherin, E cadherin. These last 3 are the markers for the tumor invasion and metastasis. So this is the various ISC tests: CD44, ABCC4, ABCC11, and Catherine, Pen Catherine. So this kind of the test will what happens? Okay, so ISC 5 biomarkers, they're on and the three clinical parameters: morphological base marker, tumor size, grade, and nodal tissue. All combined together is the KNSS breast risk scoring system, and the cutoff value is the 15.5. If patient breast tissue cancer tissue achieved less than 15.5, that is low risk, and if it is more than, it is high risk. So if you test 100 patients, 70 patient may be a low risk patient and high risk will be 30 patient. If you don't do the test in this kind of the breast cancer, you all will be subjected to the post operation chemotherapy, adjuvant chemotherapy. So this test has been validated in the 4,000 plus patient, including the patient from India, US, and Europe, and Middle East also. High accuracy, 95% negative predictive value. That means if they say it is negative, it is low risk, then it is low risk. Patient granted in India, US, China, Europe, and Canada. Many peer-reviewed scientific publications are there, which we will list in last. Who are eligible patient for the KN-assist breast test? Female patient, invasive ductal carcinoma, invasive lobular carcinoma, metaplastic, and mucinous cancer. Generally, in metaplastic cancer and mucinous cancer, I haven't sent patient for the KN-assist, but it is applicable to them also. Hormone positive patient, HER2 negative patient should be there. Early stage, that is T1N0, T2N0, T3N0, T1N1, and T2N1. So this kind of the patient, they should be sent to the KNSS test. K67, any grade, any age. Exclusion criteria: male patient, they haven't done. DCIS or inflammatory breast cancer, they are already high risk. DCIS, they haven't included the data. ER negative, PR negative, the TNBC patient are not eligible for that. And advanced stage patient like 3BCC, that is T2 N2, T3 N2, T4 N1, and any T which is including N3. Stage 4 patients are not included in this. So global validation, you can see the Indian subcontinent, then in the Western Europe part, and some part in the America. It is validated there. So how this report comes, we all are very well versed with this report. In this particular report, the cutoff value is 23.1. So that is around high risk patient. This kind of patient should go for the chemotherapy. So they have mentioned like 5-year probability of distant recurrence with hormone therapy alone is 19%. So this patient should be receiving chemotherapy. And this is the total validation cohort of 4,000 patient who received chemoendocrine therapy. So patient divided into two, high risk and low risk. So low risk patient was 69% and high risk was 31% patient. And if they receive according to this, then the almost 7.5 year survival is 94% in this patient subgroup. This is again the same N0 and N1 disease according to the node positivity. So KN-assist breast stratifies both these groups significantly with the low risk NP of the more than 92% negative predictive value. And here the only high risk patient are benefit with the chemotherapy. If you give the chemotherapy to the low risk patient, there is no survival advantage of the chemotherapy. So this patient, this set of the patient should be prevented with the chemotherapy side effects, and they should offer only endocrine therapy. If patient are high risk by KN assist, they should be receiving the chemotherapy. This is the bar diagram which shows the percentage of the high risk. If patient is you test the patient T1, T2, or N0, then 10% patient will be high risk, and the 13% patient will be low risk. And here is the less than 5%. K67 is 6%, 29%. Then it is 85% will be low risk. So if you compare the can assist versus the Oncotype DX, then you can see these are the highly comparable test, and the concordance is 83% in the low risk stratification. So this means like if you test the 100 women with both the tests, then 83% chances are there that low risk will be classified as a low risk by both the tests. So great concordance, and there are 10 years distant recurrence risk prediction in the breast cancer by KN assist. In Dutch sub-cohort of the randomized team trial, so they have classified the like 433 patients validated by the KN assist, and they achieved the tumor blocks from the Lumek Netherlands labs. And this cohort is primarily postmenopausal, not positive, and treated with the hormone therapy alone. So you can see the results. This KN assist breast high risk patient have significantly higher risk for distant metastasis in the total cohort, lymph node negative and lymph node positive subgroups. This is the multivariate analysis. So we'll skip that. Yeah, few relevant guidelines regarding the prognostication of the EBC. So they have featured here like KN assist breast test and Oncotype DX are the recommended multi-marker prognostic tests that have substantial documented evidences. So in the Asian Geriatric Oncology Society, they have approved it, and there is a detail of clinicopathological parameters of the KN assist breast in 2016 to 24. This is the real world data, and they have the paper on this. So paper published by Sumita Ghosh, where they have mentioned this like KN assist breast risk stratification was conducted in the almost 3,000 patients with a known percentage of the ER standing in both ER 1 to 20% and ER more than 20% subgroup. So there are the various classification. We'll skip that. Real world evidence of the impact of the KN assist breast on physicians' decision about the use of adjuvant chemotherapy and breast cancer, early breast cancer. So in the last 6 years, we are using this particular test, KN assist breast, and we are classifying the patient who present with the low risk disease, clinically low risk. So from our center, Dr. Ajay Bafna has participated in this particular publication. Dr. DC Dowell, very well known figure, and across the India they have collected the data. So with this in this paper they have said like clinical risk stratification, low risk for 52%, intermediate risk for 27%, and high risk for 21%. When this were tested with the KN assist breast, then 67% patient found to be low risk. These are the flow diagrams which is script. And in ESMO Congress 2024, they have presented a paper with Dr. Vashisht Maniyar and Senthil Rajappa, real world data on prognostication of early stage breast cancer using the KN assist breast, first ISC best prognostic test developed and validated on the Asians. So it was presented in ESMO 2024. Then various other papers were also presented, and real world data was shared in the world platform. So this was a poster publication in the ESMO breast cancer. This is Asia Pacific Breast Cancer Summit. They have presented a poster there, and now KN assist breast reaches worldwide. So you can say like India, Turkey, UAE, Saudi Arabia, Sri Lanka, Bangladesh, and Iran. They are doing and stratifying their patient with this KN assist test. So what is unique about that? It is now it is multi-country validated, affordable innovation, almost 5 times lower price than the multi-gene test, and it is AI based, cutting edge ML versus competitor potential for drug development, ISO quality driven, and the fastest turnaround time 7 to 8 days. If you send Oncotype DX, it takes almost 3 to 4 weeks. So treatment will be delayed. They have the various publication in the various platform. You can see this Springer Nature, they have published cancer medicine, breast cancer research, and various prestigious platform and books they have published. So summary, KN assist is proteomics, an AI-based prognostic test validated on the Asian and Caucasian patient, performed as a service in a central lab and reported in 8 days, which is very less turnaround time. K-based risk stratification is independent of cohort-specific differences, age and nodal status. Chemotherapy benefit is observed only in the high-risk patient. More than 83% concordance is observed between the oncotype DX low category patients. Patient treated based on the K-assist breast. Risk stratification show excellent outcome post 5 year of follow-up. This negative predictive value is at least 95%. K-assist breast can predict 10-year recurrence risk as evidenced by the data from the TEAM trial, and it can help in risk stratification in intermediate Ki67 group. So K-assist breast is our solution to our problem, where breast cancer is different from the other Western countries. So thank you very much. And now, if any question, I am open to that. And thank you all the participants, speakers, moderators for participating in this program. And we will be meeting next year now. So thank you very much. Thank you, Team Horizon, for making this Onco Forum 2025 possible. Thank you, Tech Team. Thank you, academic partners, AstraZeneca, Reddy's, Dr. Reddy's Lab, Glenmark, GSK, Merck, Zydus, Alchem, and Lupin, Sun, and Stents. Thank you very much for participating in this academic quiz. And thank you and good night. We'll meet again next year. Thank you.
Thank you, sir.
Thank you, sir. Good night.